Good morning, good afternoon, good day to those of you all over the globe. It's Dawn Benson here, and I've just started the recording for our second School Health webinar on monitoring and reporting. And I would ask Doug McCall, if you, and perhaps several others of you, to just write in. Okay, so someone says they can barely hear me, so I'm going to turn up my microphone. All of you at the bottom of your screen have a set of bars. The top one is your microphone, which is important to us presenters, and the bottom one is your speakers, which you can turn to the right as far as you can. Everyone's audio is a bit different, but thank you. It sounds as if people can hear me a bit better, and Doug, if you could write a little note too. So welcome to everybody. Today's presentation is coming from a number of presenters. Koji Miyamoto will be speaking to us from Paris. Kathy Wilbur from the state of Maine. Chris Fowler will be presenting information from South Carolina, but she's in Detroit today. And Nancy Hudson, who works in Washington, D.C., will be presenting from Maryland today. I know it's a very exciting day for Americans, for the whole world, and we'll be finished in time for everyone to be able to watch the inaugural ceremony of President-elect Obama. So our best wishes to our American colleagues on this momentous day. And thank you for our participants who have registered from around the globe. Registrations have come from Canada, from the U.S., from the United Kingdom, from a number of European countries, as well as Australia. And I'm sure I've missed some, and Doug McCall will remind me later. And we have a number of people coming on this morning to listen today to the actual live webinar, and quite a number who will be taking part in the recording. A lot of people registered and then contacted me that they would be unable to take part at the actual time, but will access the archived version. So this is being recorded so that you can access it later. Just a little thing about the audio. Audio is kind of key here, and it's coming through your computer, so that's perhaps a bit different instead of a conference call. Be aware, because it's being downloaded, that sometimes it will slow down and then speed up. And I see someone is saying that the sound is very poor and there's a lot of interference. So I will put my mic up a bit and see how that is. So if you could write me a couple of messages just how that is working now. Much better. Okay, so keep letting us know about the audio. But just want to let you know that you may have a gap from time to time, and then it may speed up a bit and our voice may get a little fast like a helium balloon. That's just the computer downloading. It's a fairly large file that comes down with this program, and then it catches up. So occasionally that may happen, hopefully not. Because we have multiple speakers with this technology, we're unable to have everyone speak on the line. So we're asking that you use your chat box, which is just down below. There's a participant box, and then there's a chat box, and you can type in you get your cursor in that little narrow box below, type in, hit return, and then you can let us know later on your questions or comments, and also keep me in line with how the sound is. Okay, now we're going to be on, we think, about 90 minutes. We're going to have time for a discussion at the end, for questions at the end. But if you do have a question along the way, please type it in, and I will keep track, because I'm not going to be the one talking. And then we will make sure that as many as possible we get the questions answered. Our first presenter, Koji Miyamoto, has been unable to get online, and so he's going to be speaking to us from my telephone, speakerphone, and so it's going to be quite hard to hear him. He's got a very gentle voice. So really pay attention to the screen, and then if you can't understand, if you've missed something, either type in the question, or afterwards you'll be able to get a hold of him and ask him more specifically. Our other presenters are all online and should be heard directly through the computer, but again, keep letting us know if there's a problem with the sound, and again, check your two bars at the bottom. The bottom one, the very bottom one, is your speaker, and you can move that up and down. So I'm going to, after saying once again, welcome everybody. I'm going to move to, I've done just a quick introductory slide about each of our presenters, the 4 that you're going to be hearing from this morning. And so I thought I would put a little bit on the screen too, just so that you could keep a handle on who's on first and where people are from. So you see, first of all, Koji Miyamoto, he's from the OECD Center for Educational Research and Innovation, which I think is probably called CERI, specializing in human capital and labor market practices. And so 2 of the things he's currently working on is CERI's globalization and linguistic competencies, and then the social outcomes of learning, which is why he's here with us today, because he's going to be presenting some background on that, some information on early key findings that they're looking at. And besides that, Koji sent me some information about himself. He's done a lot of writing, and certainly in the area of brain research. He's done a lot of work on learning, and so in one of the things that I read about him, he was part of the BRAIN team. So he's starting with us this morning, and hopefully you'll be able to hear him clearly enough that you'll get the main idea of what he's sharing. And much appreciation to him for sort of going to plan B. We've had several tests and haven't been able to get his computer system past all the security measures so that he could download. So Koji will speak first, and then he'll be doing sort of the big picture, the big overview of the framework that he's looking at. And then Kathy Wilbur will present next, and she's going to be speaking about the Maine Department of Education health education that she was working with and responsible with for many, many years. She's currently the manager for the Alliance for a Healthier Generation. I've put that up on the screen. But she is going to be speaking to us about the Maine Educational Assessment. She worked on that for 10 years, and she's director of the development of it and did the work with it. So that's what we're going to be looking at this afternoon from her. Then you're going to hear Christine Beyer, and she's speaking to us from South Carolina from the Department of Education. And she's worked with a colleague, Lynn Hammond, but I think Chris is going to be the one presenting today. Well, I know she is. And she's had 35 years in public education. She's been a teacher, university professor, researcher, and grant writer. But today, what she's going to be talking about is the work that's being done in South Carolina. So again, we're going to see what has happened in Maine, what's being done in South Carolina, and then we're going to finish with Nancy Hudson. And again, you can see what I wrote up about her. She's from CCSSO, Council of Chief State School Officers, and she's done a lot of work on the Health Education Assessment Project. And so she's going to speak to us about that. And that involves 22 agencies, so it's very interesting reading that work. And if I've missed anything that you think you should include our presenters, please do as we move along. Now I'm going to move to the very first of Koji's slides, and I'm going to bring him very close to my microphone, and we're going to go from there. So welcome, Koji, and we've got your first slide up, just the welcoming slide, Social Outcomes of Learning, and I'm going to click to the first slide, which says the outline. So over to you, Koji, and let us know how you can hear Koji. Thanks.
Okay. Thanks, Dawn. Well, hello everybody from Paris. I would first like to say thank you so much for inviting me to this international school webinar. It's the first time I participate in such an event, such a high-tech event, and you've already seen the miserable result from our institutional technology side. But anyway, I think we'll manage. So since we don't have much time, I'll quickly go through the main points of my presentation. So I'll spend about 2 minutes talking about the OECD and the Center for Educational Research and Innovation, where I come from. In case I suppose many of you might not know about our organization. Next, I will also briefly explain the background of the Social Outcome of Learning project, and then I will spend about 10 minutes going through 7 or 8 key findings that we've gathered in the past three years of this work. Okay, so I'll go ahead. Next slide, please, Dawn.
Okay.
Okay. Okay. So the Organization for Economic Cooperation and Development, we're essentially a group of 30 member countries committed to democracy and the market economy. And maybe some of you may know us from the statistics and economic and data that we publish very frequently. However, we also provide a lot of analysis and economic forecasts. And that would be an important basis for governments, member governments, to implement their policies as well. And we also conduct a variety of research on pretty much any issue that government engages in, apart from, say, national security. So you see that we work on trade, environment, technology, and obviously education as well. Next slide, please.
Okay.
Okay. So essentially, the objective or the goal of the OECD is to help governments to compare policy experiences and to seek answers to common challenges such as migration, aging population. We also identify good practices across different countries. And finally, an important element of our work is to coordinate domestic and international policies. Next slide, please.
Okay.
Hello.
Hello. Yeah. Can you hear me?
Yes, I can hear you now. Yeah.
Yeah.
So you're on slide number 6 with the whole chart, the figure.
Yes.
Okay, great. So this figure gives sort of a bird's eye view of the whole organization. And I'm not going to go through the details, but you can perhaps see that it is like a government itself. It's with a variety of directorates and departments. And one of the departments that I come from is the Directorate for Education. Next slide, please.
Okay.
Okay, so this within the Directorate for Education, there are obviously a variety of divisions working on different issues, and in particular, I come from the lower left part, which is CERI. Essentially, what we do is to generate forward-looking research, analysis, and synthesis. We also identify and stimulate educational innovation. And another important mandate that we have is to promote international exchange of knowledge and experience. And I think, especially on the last part, I think we share similar goals with what you are doing in this initiative. Next slide, please.
Okay.
Okay, so I'll quickly go through the overview of the social outcome of learning project, which, as you can see on the screen, which was launched in 2005, and reflecting the challenges that the OECD countries have been facing on a variety of issues, including health and civic and social engagement. The CSE stands for Civic and Social Engagement. And also with a growing understanding that education or learning can play a significant role in improving the health and citizenship outcomes. So essentially the objectives of the SOUL project is to synthesize our understanding on the relationship between learning and these two domains of outcomes, which is health and civic and social engagement. We also aim at better understanding types and forms of learning that matters. we also try to contribute to the knowledge base by actually conducting original empirical analysis. And finally, we also aimed at trying to better understand the policy context that from which the policy context of the 30-member governments. Next slide, please.
Okay.
Thank you. So for this project, there are a variety of countries that had participated, covering Europe, North America, and Asian Pacific, and Canada, US, Australia. I think those are the three countries where the audiences, the participants are from, are also included in this project. So essentially, we gather experiences, evidence, data from these variety of countries and try to have a synthesis of the understanding of the relationship between education and social outcomes. Next slide, please.
Okay.
Okay, thank you. Instead of trying to assess the impact of education on health and civic and social engagement as a whole, we decided to focus on certain subdomains of health and civic and social engagement. As you can see, we looked into obesity, drinking, and mental health on the health domain, and volunteering, political interest, and trust, interpersonal trust and tolerance for the civic and social engagement domains. Next slide, please.
Okay.
Okay. So the next, actually, the rest of the slides. In the rest of the slides, I'll essentially present the key findings from the three years of work. Okay, so I've made the slides very simple so that it can be easily understood. But if you have a more detailed question, if you want more further information, please do ask me for that. Okay, so the first question that we had asked ourselves when running this project is, do policymakers generally see the role of education in raising civic and social engagement and health outcomes? We try to address this question by sending out country questionnaires on policy issues, on policy objectives, and also on policy initiatives that different countries are doing. We found out that generally, yes, the governments do see the importance of education in raising health and citizenship outcomes, and we found out that they feel a stronger role of education for health outcomes in particular. And then we also asked, if that's the case, are these understanding translated into concrete policy actions, policy initiatives? And on this, we found out that it was actually not so much translated into concrete programs. And this was especially I think I'll skip that, but and then we thought about why. I mean, why, although governments seem to be enthusiastic about the potential role of education in raising health and citizenship, why aren't they implementing concrete programs? We found out, our guess is that our knowledge base it doesn't provide yet the detailed information, such as what type of education works best, or what forms of learning might help most to raise the health outcomes. But these kind of information, more detailed information, are still not available, and it's these kind of information that helps governments set up concrete policy actions.
And before you go to the next slide, Koji, there's a question from Claire Blanchard from IUHPE asking, which countries did you send the questionnaire to for the role of educational policymakers? So do you know which countries you could speak to?
Yes. That's essentially the country. Okay, I'll tell you that. It includes the Belgium, the Flemish, the government, Italy, Luxembourg, Netherlands, Norway, Sweden, the United Kingdom, Australia, Canada, Korea. That's it.
Great, thank you. Okay, over to our next slide.
Okay, so we have key findings 2.
Great, that's where we are. Great.
Okay, so the next question that we asked, we're going more into the research part, is does education have a causal impact on the level of citizenship and health outcomes? And this was actually a very important question, not only for the researchers, but for policymakers, our governing boards of the OECD. And it's very difficult to give a very simple answer to this question. But I would say that generally there seems to be a causal impact of education. When I say education, it's mostly the years of education or educational attainment. There seems to be a generally causal impact of education on health and citizenship. However, the evidence is rather limited for certain types of outcomes, and there are mixed results. Some showing positive causal impact, some even showing negative ones. That was especially the case when we analyzed the impact of education on drinking or alcohol consumption, for example. We had a stronger evidence for obesity and mental health outcomes. So just to give you an example, we found, for example, for Sweden, for a cohort of men born between 1945 and 1955, an additional year of schooling improves the likelihood of being obese by approximately 12 percent points. So these are the kind of evidence that we have gathered. Next slide, please.
Okay.
Okay. So perhaps a more interesting question, both for researchers and policymakers, is how actually education might affect social outcomes. What are the possible causal pathways, causal mechanisms? And there's been a lot of theoretical work done to link between education and various social outcomes. And this slide shows some of the most interesting possible causal pathways. For example, education could improve generic competencies such as literacy and numeracy, which may help raise social outcomes. And these competencies might be more specific competencies, such as health literacy or citizens literacy. Can you actually go to the next slide, please?
Okay, and before you go there, we have a question, Koji, from Doug McCall, and it says, in Canada, all provinces have health and social outcomes stated as part of the core mandate of schools. Is this the case for most OECD countries?
I would say not for all the OECD countries. Actually, it's actually a few number of countries would have that. But sorry, let me think, because if you say mandate it, explicitly, I think there's hardly any country that seems to have done it at the level of the Canadian government or provinces.
Okay, thank you. Now I'll go to the next slide.
Okay.
Okay.
So just to give you an example of how education might help raise competencies and how that would lead to better health outcomes. This slide might be interesting for you to see. This is the recent research done by Canada, the Canadian Council of Learning, which shows that an increase in health literacy reduces the prevalence of diabetes in the population. And this result still holds after controlling for of individual characteristics. Can you go back actually to the previous slide, please?
Right, key finding 3.
Exactly, yes. So the second causal pathway is through information. So obviously schools could provide a very specific health information on health, and that may help improve individuals' ability to monitor their health or take care of their own health, and hence would improve their health outcomes. So this is an obvious second causal pathway. Another interesting causal pathway that we have looked into is the psychosocial features of the individual. So this I mean, for example, resilience, patience, or even self-esteem. There's been a lot of work done showing that education can help raise the resilience, patience, and self-esteem of individuals, and those psychosocial aspects are also have been shown to have an effect on individuals' capacity to raise the health outcomes. The next causal pathway is through the labor market. Obviously, education would help increase the labor market outcomes, and since that would help individuals purchase healthcare goods and services, it may help improve the health outcomes. And lastly, education can also change the social context that individuals are placed. For example, education can change the residential the area of living, residential choice of individuals, and that could shape individuals' citizenship participation, for example. Can you go to the next? Can you skip the next slide and go to the one after that?
Key finding 3.
Findings 3, exactly, yes.
Right. Okay.
Okay. So just to give you one interesting work that we've done, an empirical work that we've done. The title is The Impact of Education on Obesity by Gender. This is Europe, but it's actually not Europe, so please discard that. Now, this figure shows for Australia, Canada, England, and Korea that generally the increase in the years of educational attainment helps reduce the probability of being obese. And again, this result is after controlling for individual characteristics such as gender, labor market characteristics, income, etc.
Okay, Koji, I have another question for you. It says, does the influence of education on labor market not impact on social inequalities and hence health inequalities? I'll repeat that. Does the influence of education on labor market not impact on social inequalities and health inequities. Sorry.
In fact, yes. I mean, we didn't look specific on the labor market channel of of how education affects inequality in social outcomes. But I will actually I have a slide that talks about that issue later. So may I actually answer partly that question later on?
Sure. Carry on.
Okay. So.
Key finding 4.
Okay. Yeah. Actually, just before going to the next one,
okay.
Just to say that in the previous slide, that given that the impact of years of education seems to have a steady impact on reducing the incidence of probability, one might hypothesize that it is not the specific information that one learns at one particular stage in school that might affect the probability of obesity. It might be more of generic competencies or that individuals develop gradually over time. That might affect the individual's capacity to handle a diet and exercise that would affect obesity. So I wanted to say that this sort of figure doesn't give the answer of which causal pathways are relevant, but it raises several possibilities that sheds light on the causal pathways. The next slide, please.
Okay.
Okay. So the next key finding, we also asked the question: might others' education, not one's education itself, but might others' education affect social outcomes as well? And indeed, we found out that parental education has a significant impact on individuals' social outcomes. It was particularly the case for the civic and social engagement outcomes. We also found out that education level in the community also affects individuals' social outcomes. Next slide, please.
And I'm just going to go back to your previous slide because there's a question, key finding 3. There's a question about, can you make a comment about what may be going on with Korean men? So we're back to key finding 3. Do you want to speak to that?
Well, I was hoping that nobody would notice that interesting. Actually, in fact, we don't have a clear answer on that. I mean, as you can see, for Korean men, more education leads to higher incidence of obesity, and that seems to be counterintuitive. I mean, my personal guess is that it is something to do with the labor market characteristics. Although we had controlled for income, but we didn't manage to control for occupations. So it might be the case that people with higher educational attainment in Korea tends to work in a certain type of occupation, which may involve some social interactions that end up raising the probability of obesity. But that's a very, very rough guess. I asked the Korean delegates, the Korean government, and they couldn't come up with a good answer to this. So I'm sorry, I couldn't answer your question clearly.
Well, it showed that everybody was watching the slides. We're going to move along because we've got 3 other presenters coming. So we're on key finding 5, and then as we get near the end, it looks like there's another question that's come up. But I think we'll just keep carrying on. So we have key finding 5 up.
Okay, I'll go fast. Okay, key finding 5 is we ask the question: what are the types and forms of learning that matter more for social outcomes? Which is probably one of the critical questions for policymakers. On the citizenship or civic and social engagement outcomes, we've tried to see if it's the content of the curriculum that matters more, or is it the style of pedagogy, which seems to be more important to raise individuals' engagement in citizenship behaviors. And based primarily on European data, we found out that it is actually not citizenship curriculum itself that's important. It's more the classroom climate, the open classroom climate and school ethos, an environment where students feel less constrained to speak out, debate. So the open classroom climate we've found out that are quite important for civic and social engagement outcomes. On the health front, we've conducted a cost-benefit analysis to see if 3 types of interventions, one is school-based, work-based, and media-based interventions worked, which among these 3 worked relatively better to reduce the costs of obesity. So that was the question that we asked. And then we found out that it is the media or school-based interventions, information campaigns, and curriculums that were relatively cost-effective drivers in the long term to tackle obesity, and that providing health classes in work settings wasn't as cost effective. Next slide, please. Okay. So an important question is that one might raise is the impact of education on social outcomes always positive? I've been talking until now as if education always has a positive impact on social outcomes. But in fact, that is not the case. Interestingly, we found out that for the UK, higher educational qualification is associated with higher alcohol consumption among women. And this is perhaps, again, related to the labor market characteristics. We also found out, and this may partly reflect on the previous question, we found out that for Australia, Canada, England, and Korea, education could exacerbate gender inequality in obesity. If you can move on to the next slide.
Yes.
Okay. Now, this slide, from this slide, you can see that generally for these 4 countries, women are either less obese or less likely to be overweight compared to men. And then, if you move on to the next slide, so
yes.
Thank you. In spite of the woman having less probability of being obese, or the impact of a year of education in reducing the obesity is much higher for women compared to men. So from this example, it shows that education could increase gender inequality in obesity. What I want to say is that education does not always improve the level and the distribution of social outcomes, it could have actually a negative effect. Next slide, please.
Okay, key finding 8.
Exactly, yes. This is my last key finding from this presentation. I think it is very important to mention that the impact of education on social outcomes is likely to depend on the synergies that educational policies have with other policy interventions. So, education is not a panacea. An interesting example that I can show you, that I can mention to you, is that, for example, for obesity, although education could help reduce the incidence of obesity, however, if you can just imagine that, even if a school provides a good class on health education that talks about obesity, if you have a bad, negative obesogenic environment, such as having abundant vending machines with high-calorie foods around the school, or if you have a bad home environment in terms of diet, then all these efforts that are made at school will not be materialized as intended. Another example can be found in Japan. Even if you teach high school kids, the problem associated with smoking, in Japan you can also at the same time find vending machines everywhere on the streets where essentially anybody can buy cigarettes. So what I wanted to say is that educational policies, educational interventions are very important, but it has to be in sync with other policy interventions in order to be effective. Next slide, please.
Great.
Thank you. So this is the last slide. I just wanted to briefly mention what are the next steps for the research or for policy communities like the OECD. From this 3 years of research, we found out that obviously we need to do more in-depth research and to collect better data. We need to learn much more. We need to assess more about causality issues. There's much more to learn about causal pathways that explains how education affects social outcomes. Although I've shown you some examples, we still don't know a lot about the types of learning inputs that matters. And lastly, for policymakers, I think it's very important to show the cost effectiveness or cost benefit analysis that compares different types of interventions. We also learned that the use of mixed research methods might be more fruitful. So far we've used primarily data-oriented analytical work, but in order to really identify, for example, the type of learning inputs that works, it might be necessary to do an in-depth, more qualitative research that would complement the data research that we normally do. And lastly, what can the OECD do in the future? We can continue working on the research synthesis that I have just briefly presented. We can also work on the data collection initiatives. That's another thing that we do at the OECD. We do a large-scale, international microdata collection, and there's a discussion to collect microdata on health and citizenship outcomes. And so there's a possibility to link that with individual competencies and individual levels of education. And finally, another important OECD work is on the indicator development. Maybe some of you would know one of our flagship publications called Education at a Glance. there's a discussion on including the impact of education on social outcomes as one important indicator for education at a glance, and that would probably raise awareness among high-level policymakers that would help push forward the research and policy efforts that we've been doing, that we've been discussing, that we will discuss today.
Okay, I've moved you to your last slide, Koji. Thank you. And there's 3 questions that if I could ask you to speak to briefly, and then certainly on our wiki we can have more discussion. So from Doug McCall, just to clarify the nature of the OECD study, the study examined the impact of the general level of education, of health and social outcomes. Was there any differentiation in the study to separate those countries that have obligatory health social education from those who don't, obligatory health social education? So back to you, Koji.
So I couldn't hear so well the last part, sorry.
Was there any differentiation in the study to separate those countries that have obligatory health social education from those countries which don't?
Actually, we didn't look into that.
Okay, and then someone has asked, would it be possible to access the cost-benefit analyses that you have done?
Certainly, yes. Well, there's 2 information. One is that we will publish a paper very soon specifically on this cost-benefit analysis. And second, I forgot to mention before that, we will also publish a synthesis report, or more of a comprehensive report that also includes this cost-benefit analysis that we've done, as well as the recent cost-benefit analysis that has been done elsewhere.
Okay, and Daniel has asked, he said he was sorry he was disconnected for a little while, and how about a combination of gender and health education? And I know that was covered. I'll just slip back to that slide, which is key finding 7, Daniel, which does show the impact of education by gender. And you can see that it is helpful for everyone except Korean men. And Koji said that he's guessing at that. Would you just want to speak to that again quickly, Koji?
Okay. So on the key findings 7, I essentially showed that women are already in a better position, better condition in terms of obesity, but by providing more education to both male and female, men and women, it would exacerbate the inequality. So this gender inequality would increase by education.
Okay. And there's a last question. How or why did you choose those 3 indicators for analysis?
That's a very good question. It was obviously not randomly chosen, but all these subdomains were chosen because it is a high priority area in the OECD. Just to give you an example, I think, especially in Europe, we found out that 1/3 of the burden of illness are caused by mental health. So mental health, well, that's one reason why mental health is extremely important among the OECD countries. For alcohol consumption, we've also found out that about 3 to 4% of all deaths within the OECD countries can be associated with alcohol issues. And for obesity, currently we estimate about 1 billion people who are in danger of being in obese situation. So all these 3 domains are of high importance among the OECD countries, and that's why we chose them.
Okay, well, thank you so much, Koji. We're going to move on to our next speaker. I've just moved the slide ahead, and we'll check that, Catherine, we can hear you. I think there is a hand being raised. Doug, I'll go off the audio, and you can speak.
I just wanted to thank Koji very much for his presentation and to allow him to slip away because he's not able to see the screen and to hear us. So. But I did want to thank him very much for his presentation, as well as for going through this Plan B in terms of presentation. It is a tribute to his skills, and Dawn, to your facilitation skills, that it went as smoothly as it did, flying blind. And Koji, thank you very much. Koji, just to say, I was not aware until you got to your almost last slide there that there is continuing work. Particularly, I know the education of the glance is very prominent in the minds of education decision makers here in Canada. Ministers of Education pay a lot of attention to that. And so I'm just noting that I will follow up with you. Perhaps there's some joint work that can be done with WHO and UNESCO and OECD, and if we can find some resources for OECD to continue to work on that. It would be very good to have OECD developing indicators in this area. So I will follow up with you very soon with that. And once again, many thanks for your presentation today. Thank you very much.
And now we're going to move along to Catherine, who I'm hoping we can hear quite well. Catherine, I think without further ado, I'll ask you to take over the control of the PowerPoint presentation up at the top, and welcome.
Hello, everyone. Bonjour. I certainly enjoyed hearing Koji's key findings on education and obesity, since the organization I now work for, the Alliance for Healthier Generation, their mission is to reduce youth obesity, and education in schools is a big part of that mission. So very interesting. I thank Koji also. As you can see, I'm going to be talking about the Maine Educational Assessment, which is our state-level monitoring system for education. And as I'm trying to move the slides forward, they're not moving. There, thank you. I just put in, so people that aren't familiar with our state, this is what our state looks like. We have a population of just over 1,300,000. You can see that we're primarily a white population. Though we're quite a large state for New England, all of the other New England states fit into the state of Maine, and we have a little over 30,862 square miles, which 90% is forest land. So you can see we're quite a rural state. And I put some data about our student population. We have just over 190,000 students, so that you can compare it to either your state or country or province. And we're going to be talking about data that's generated at 3 different grades, 4th, 8th, and 11th grade. So that's why I put down the student population. 4th grade, it's a little over 14,000. 8th grade, it's a little over 15,000, and 11th grade, almost 15,000. So we will be referring to those 3 grades as I move along. So that's just a brief overview of our state. Now, the Maine Educational Assessment, we align all of the items to our state standards. The Maine Educational Assessment started out with reading, writing, math, and science, as well as social studies and humanities. And then health education was added after 7 years that the test had been going on. And just a little backstory, it took a lot of advocacy to make sure that health education was included with the state educational assessment. So it was quite a coup when that happened. And we actually started one grade at a time. We started with 4th grade, moved up to 8th grade, and then finally 11th grade included the health education component. So as I said before, the test was administered to all students in grades 4, 8, and 11. Not a sample, but all students. However, what they got was one of 12 forms. And what we had on each of those forms was a common section. So it included some questions that every student would get, and then matrix sections, so that there was an additional section that was different on each of the forms, so that we could include a higher number of items. And in some cases, we had as many as 144 items that we could generate for 1 year's testing because of the matrix format on all 12 forms. We had multiple choice and constructed response items, and I'm going to show you some examples of, or an example of each of those kinds of items. And I thought you'd be interested in knowing that how we field tested the items. What we would do is embed items that we thought were well developed and would work well with students. We would embed them in 1 year's test. We would look at the data and then decide the next year if they would go on and be included in the reporting. So that's how we field tested the items, by embedding them in the prior year's test and then seeing if they worked well. Okay, the next slide. I just wanted to take just a moment to talk about the standards-based approach to the assessment. As I said, all of the items were aligned to the standards, and this is just an example of one standard. This is our first standard. We go by ABC. So this was our A, health concepts. Students comprehend concepts related to health promotion and disease prevention to enhance health. And I'll just take a minute here to explain that our standards, our state standards, was based and adopted from the National Health Education Standards. And then the next level down is performance indicator level. And why this level is very important is that schools will build their health education curriculum on the performance indicators, as well as when we were building items for the state assessment, we would align them to the individual performance indicators. So if we take just a moment to see how the performance indicators build from year to year, from grade span to grade span. The first one, pre-K2, students recognize that healthy behaviors impact personal health. And we always looked at the level of cognitive demand of the particular performance indicators. So here we have students recognizing. The next level, grades 3 to 5, you'll see that we're having students explain now the relationship between healthy behaviors and personal health. And then as we move into middle school, grades 6 to 8, you'll see that we're asking students to examine and to be more intuitive about the relationship between behaviors and personal health. And you'll notice here it's not just healthy behaviors, but all behaviors which could be both healthy or negative. And then at the high school level, grades 9 to diploma, students now are asked to predict how behaviors can impact health status. So both the levels of cognitive demand become more sophisticated, as well as the concepts themselves within these individual performance indicators. And I just want to point out that our standards do address what are the most essential knowledge and skills that kids need to adopt and maintain healthy behaviors. Okay, so the next slide, I thought I'd just talk briefly about the item development process. It was a process led by committee, and we included grade span teachers. In other words, if it was middle school, test, we were developing the items for grade 8. Then we would have teachers from grades 6, 7, and 8 on the committee. We had administrators, we had curriculum developers, and we had principals, as well as the Maine Department of Education Health Education Specialists, by which there were 3 of us. And what the committee would do is we would adopt, adapt, and in some cases develop items. And I put SCAS here, which is the State Collaborative on Assessment and State Standards, because Maine was part of this Council for Chief State School Officers initiative, and I know Nancy Hudson's going to be talking about that at the end of this webinar. So just wanted to reference the fact that we did belong to that initiative, and we did adapt or adopt many of those items. So once we had developed items, we, as I said, would field test them, and then the group would actually look at the data from the field test and decide, are we going to accept that item? Are we going to adapt it and then field test it again? Or is it just an item that just did not work and we just rejected it? So the committee actually made those decisions based on the data from the field test. And then the committee also was responsible for developing the scoring guide for the constructed response items. So you can see this is very much a teacher-based process. Now the Maine Department of Education, along with the contractor, finalized the items and would develop the forms by balancing content and standards. And let me show you what the considerations were as we were developing items. We would look at categorical concurrence, so making sure that the item did connect to a standard at the performance indicator level. We would look at depth of knowledge consistency, so again, alignment of the level of cognitive demand. We would look at cumulative growth in content knowledge, so the assessments needed to show the increased complexity of the content knowledge through the grade span continuum. And as I showed you in the previous slide, the content, not just the level of cognitive demand, but actually the content knowledge increased as we went from grade span to grade span. And then, of course, we looked at fairness. Was the task clear? Was it free of bias? And then we tried to scaffold as much as we could so that we had many parts, and that the first part would allow all students to enter into the item so that they could show what knowledge they had or what skill they had at a different range, beginning at a kind of entrance level and then work up its way up through. And I'll show you that when we look at one of the items. These are the reporting categories on this slide. What we did is the schools would get a report, and they would actually find out how their students did in each of these categories so that they could look at their curriculum or their instruction and decide where they were doing a good job and where they might need to look at improving. So the health education content areas were, we clumped them into 6 reporting categories. The first being prevention and control of disease and disorders. And then we had substance use and abuse, which would include tobacco, alcohol, and other drugs. Then we clumped community, consumer, and environmental health into 1 reporting category. Family life and growth and development was another category. Personal and nutritional health was combined into 1 reporting category. And then the last was safety and accident prevention. And then the schools also got reports out by category of standards. So we have 6 health education standards, so that each item was categorized by grade, by standard, and by health education content area. And so again, schools would get reports out and how well did their kids do in health concepts? How well did they do in the standard around health information products and services, around the standard of health promotion and risk reduction, influences on health, and communication skills, and we included advocacy skills under this category of communication skills. And then the last reporting category for standards was decision making and goal setting. We used a 4-point scoring rubric, and a 4 meant that the students exceeded the standards, went well beyond maybe the level of cognitive demand, or went into great detail and showed an outstanding understanding or demonstration of skill. We usually got about 2 to 3% of any item where the students would score a 4. Then a 3 meant that the students met the standards. That's what we had. They demonstrated, they knew or could do what was asked of in that particular item. A score of 2 meant that they partially met the standard. They showed some understanding. They may have had some miscues. And then 1 does not meet the standard. They had little. They gave little information or documentation that they could understand or demonstrate the skill. A score of 0 was that the response was irrelevant to the skill or concept being measured, and then we had blank where the students did not respond at all. So that was our scoring rubric. Here is an example of a constructed response item for grade 11. And you can see where I was talking about scaffolding. A would be that they would simply identify one voluntary health organization, such as the American Cancer Society, the American Heart Association, the American Red Cross, or a local or state voluntary organization. So they would simply identify one health organization. B, they would create a public service announcement that includes 2 convincing reasons teenagers should volunteer for the organization that they identified. And then C, they would explain why their announcement would be convincing to teenagers. So basically, we were looking at community health and then the standard around communication. So as we work our way through this item, I wanted you to see what was the demonstration that they had to provide to show that they scored a 3, where they would meet the standard for this particular item on the scoring guide for voluntary health organizations. So the response of the student would demonstrate a general ability to adapt health messages for a particular audience, this case being teenagers, by creating a public service announcement with convincing reasons why teenagers should volunteer to work for the organization. And also the response includes a general explanation of why the message would be convincing. So that would be a score point.
It's Dawn here, and I know you have quite a few slides.
The standards.
So just asking you to kind of move along a little faster. It's Dawn here, and I know you have quite a few slides.
Okay.
So just asking you to kind of move along a little faster.
Okay, great. Thank you, Dawn. And this slide shows what the committee would look at after that particular item was field tested. It shows the difficulty, the discrimination, so how many students scored for that particular item, and how did they do with that item versus other items in the test. We looked for differentiation between male and female responses, and then you can see we actually identified the number of kids, of students that scored 0, score point 1, 2, 3 met the standard, or 4 exceeded the standard. And then on the other row it shows the percentage of the total and then the mean critical score. And so that's the data we had as we were deciding whether or not to keep, adapt, or reject an item. And the next item, I wanted to just show you an example of a multiple choice item. This was from grade 4. So this is Mary is allergic to nuts. She wants to buy a new brand of oatmeal bread. The best way to find out if this oatmeal bread contains nuts would be, and you can see the 4 choices that they had, and I want to show you the data that comes from a multiple choice item. This difficulty was less than 1%. The discrimination of how they did with this item based on the other items in the test, you can see the differentiation between male and female was non-statistical for this, and you can see that the majority got the correct answer, that they would read the label as opposed to asking the grocer or who ate the bread and what the ad was. So this was the data we received for multiple choice items to decide whether or not we would keep, adapt, or reject. The schools would get, as I said, individual school reports, and they would get them by content area. So this one was Family Life Development, Growth and Development for grade 4. And then this was one for grade 8, Community, Consumer, and Environmental Health category. And then I just wanted to show you that this is a grade 11 example where they got information based on the standard category, this one being Health Information, Services, and Products. And you can see this particular one where they showed school, state, and district data. The one kind of very interesting fact that I wanted to share with you was we looked at the gender gap in learning health education. We observed data for 4 years, 1998 to year 2002, and just wanted to show that females did better than males in every grade, every year. And then across grades, the difference between females and males increased from grades 4 to 11, the average difference being 7 points at 4th grade, 12 points at 8th grade, and 17 percentage points at 11th grade. Now within grades, the difference between females and males was generally consistent over the 4 years. And among females, the scores generally increased or were fairly consistent from grade 4 to 11, and among males, scores generally peaked in grade 8 and then decreased in grade 11. And I'll just quickly show you the charts from those 4th grade. And you can see the difference between male and female in 1998 to 1999. And then the next year, or the next set of years, 2000, 2001, and then 2001 to 2002. And you can clearly see the difference between the males and females on all 4 years. And the last point I wanted to make is that we were moving along very well for about 10 years, and then the federal legislation, No Child Left Behind, the Elementary and Secondary Reauthorization Act at our federal level, determined that states needed to look at adequate yearly progress, how well the students were improving in their learning in math, science, and reading. And so we were using our main educational assessment to determine adequate yearly progress for schools. And so it was decided that we needed to increase the reliability of those subjects on the test. We needed to have more items in those areas since they were now high stakes. And so the decision was to eliminate all the other subjects other than science, math, and reading. So health education was eliminated along with social studies and the humanities. And if we have any time at the end of this session, I'll talk about how we then went to building a local assessment system for determining if the students met all of the standards, including health education and physical education for high school graduation. So here's my contact information.
And thank you, Kathy.
With my address, phone number,
I'll
and
get you to turn off your audio. Thank you. And I'm sorry we're running out of time.
Contact me and have any questions.
So I'm going to move right along to Dr. Christine Byer. Thank you, Chris.
And thank you, Kathy.
Good morning, Kathy. I did have a question. For your review of the items and giving them a score, how did you train those people that were doing the scoring, and how long did that scoring take?
The scoring was done by the contracted company, and what we would do as a group is we'd bring in a group of teachers. They would look at student work and decide on cut points for each of those scores, 1, 2, 3, and 4, and then choose exemplary papers as benchmark papers to use for each of those score points. And then they would train, they would actually pay teachers to come in and score the constructed response items based on explanation of what would be a acceptable answer, which the review committee had to write, and then they would look at the benchmark papers, and they would have 2 readers for each item, and then they had someone that was a read-behind person to make sure that there was consistency with the scoring, and if there wasn't, they would stop the work and then re-educate the reviewers, and then they would continue on. So it was quite a lengthy process for scoring constructed response items.
Okay, and over to Chris. Thank you.
Okay, good morning. I would like to explain what we've done in South Carolina with our health education assessment. We're actually starting our second full year. So I'll just move ahead to the next slide. And what had happened was there's 2 pieces of legislation that do impact assessment and standards in our state. We've had a law in place for 20 years. Actually, we're going into our 21st year now, which is the Comprehensive Health Education Law that mandates that 11 subjects be taught, topic areas be taught. Although we have not had a distinct way of assessing that instruction is being done, other than each year we do ask our district level health person for that information. And beyond that, we don't have any, we haven't been gathering data for those 20 years. We have additional legislation that I'll show you on the next slide that allowed us to move ahead with that process. And what we did was we examined the program of how health education is being delivered across the state, because in South Carolina it really looks different in different districts. There's different certification requirements required of the teachers. Some they can be certified in science, they can be certified in health and physical education, health by itself, or physical education by itself. So we wanted to take a look at who's actually teaching health education across the state, and then compare teacher quality issues to student assessment and student assessment based on our 2000 standards, which we are now revising. We will have new standards this year that look very similar to what Florida has just released as of December. We'll be having performance indicators across all grade levels in our new standards rather than what we had before, which was benchmark in grades 5, 8 in high school. So we decided we have a assessment committee that decided we would look at, in high school, we would look at the 10th grade student, because most of the students in South Carolina get their health education instruction in the 9th grade. So we thought to wait until the 12th grade would probably be too long. So this is why the 10th grade was selected as a student benchmark for our standards and assessment. Moving to the next slide, this is the law that helped move us forward with health education assessment. And I actually put in a clip of the law here that shows how it's stated that we will do, we will look at program effectiveness and adherence to standards. So we're doing program assessment. We're required to pilot it in 06-07. We ran a little bit behind on that and do full assessment for the state in 2008-09. We developed a plan. The committee represented people from university level, classroom teacher levels from all of the benchmarked areas, and we determined we wanted to do full program assessment of health education. We needed to look at the whole package. We wanted to look at the teacher's background of who's teaching it, what kind of support they get from schools and the school and the administration, how the health education is structured differently in their schools and in their district, what the teachers actually teach, and then of course student outcomes. So we wanted to look at all 5 of those variables, and within those broad variables we had other categories that we looked at. For example, we looked at partnership and leadership and teacher quality. For example, a teacher quality question would be, what's your academic qualification to teach? What's your certification area? Another question we would ask, have you had professional development, in-service activities in health and safety education? How many professional development activities or in-service events have you attended? In our partnership, and this is all under teacher background, under partnership and leadership, that comes under the school partnership and leadership. We would ask questions like, are you a member of a wellness committee at your school? Describe how you collaborate with parents and other teachers. So we had we developed a lot of open-ended questions on our teacher survey. And our teacher survey was actually an online survey that the teachers filled out. And I'll go into more detail here on how we did that. We did the pilot assessment first. With our student assessment tool, we took multiple choice items from the CCSSO HEAP data bank, and our committee actually did an alignment of some of those questions to our standards and made sure that we had equitable coverage of those items. I'm trying to mark this here. I think I'll have to do it this way. That we made sure that we did a table of table of specifications where we made sure that we were equally covering our standards. And then the committee took a very close look at cultural literacy, because they felt that in South Carolina, some of the wording that was on the national national database, in some regions of our state, the students may not be able to understand the terminology. So we actually did some revision to make it culturally more appropriate for the South Carolina population, which I thought was a fascinating thing that came out as a result of the committee work. We had 3 levels of committee members looking at elementary, middle school, and high school the multiple choice questions from the data bank. And that's what we were using. And they met for a number of days to pull out items that matched. And okay, moving along, in preparing the pilot test, we randomly selected 90 schools across the state, and then we sent out clearance letters to superintendents. It was totally voluntary to participate in the pilot. The items we selected had 75 items on the test forms. We had 3 test forms, and of those three test forms that we created, and we randomly selected those 35 items on the test, and then there were 15 items that were common to all 3 test forms. We also collected information on students' grade, school, gender, ethnicity for the purposes of reporting back. However, we did have an issue with the pilot test, in that many of the schools that participated wanted to know their results. And because it was a pilot, we had to explain to the school that we're only using this information to revise and revise our items. Therefore, we did not share that information with the schools in terms of how their students performed. Before we started the pilot test, the same teachers who actually did a survey online, they went through a training in March and April of last year, and they were emailed a practice test and actually practice logging in and how to give their students ID numbers and get their students to log in. So we had a practice session for the teacher, and they worked with one of our contractors at the time, Metalogic, who also contracts for the national CCSSO and Nancy's group. So Metalogic helped the teachers set their students up for the testing. And that went very, very smoothly.
Excuse me, Chris, I'm just
and then we
see
developed
if you
the
could
database.
move along
Yes.
through the results. Just because we're waiting to bring on Nancy.
Move along
For the conclusion.
just because we're waiting to bring on Nancy.
Absolutely, I will move quicker. I think I only have about 11 slides, so I'm almost done here. In the pilot, we had about 5,000 students, 37 schools. You can see the breakdown here. The average score for students was 25.4 of 35 items. And what we found was that our multiple choice testing wasn't discriminating enough. So we decided to meet again as a committee. The assessment committee met to revise the items, and we're using technology. These are online items. We're going to actually do some dramatization and some scenarios and allow students to do extended response or the selected response from these complex scenarios where they have to do a lot of skill application to pick the correct response. We have limited funds for doing scoring, so we're still going to design this around the multiple choice in terms of response, but yet the complexity of the item is going to increase significantly. That's our plan. The teacher survey, 77 teachers responded, and I just did a brief summary of, and that was a 61% response rate. 77 teachers were emailed the survey because they were identified from those 37 schools that agreed to participate. I pulled out just some basic information. There were no certified health educators in the teacher survey. So we have some issues here in South Carolina that we're going to address related to certification. Only 42% do professional development and had the opportunity. Long-range planning for health education instruction was about 50-50, and most teachers use the state-adopted textbook for their instruction. They don't use much supplemental material. So what we plan to do with the teacher survey is to modify that a little bit, and then we're going to have fewer open-ended questions because responses were all over the place. So we're going to give the teachers more questions with selected response, and we also decided that it would be important to have different teacher test forms, survey forms for their grade level, because we thought that the survey was a little confusing. If you say you were a high school teacher and you're doing the general teacher survey, it was a little confusing. So we're going to modify the teacher survey into 3 instructional levels, elementary, middle, and high school. Okay, going to the I think I have the last slide here. In the immediate future, we're scheduled to do, we have a state university contractor who's been helping us with the assessment, and we're scheduled to do one of the 3 regional trainings of the state. We break the state into 3 regions, and we're going to do 3 cycles in 3 regions of the state. We're planning on doing one of the assessments, or the first cycle of the assessments in April. However, with all the severe funding restrictions that we have, that's been put on hold. So what we'll probably be doing this year is working on those more complex items and possibly doing some piloting on those. We doubt we'll be able to do the full assessment this year because of funding. And that's our biggest problem. But we were ready to go. And again, we'll be testing in grade 5, 8, and 10 when we go. We are still doing online regional trainings for teachers. We did that last summer extensively, and we'll be doing web instructional courses for teachers to get them used to more advanced skill level assessment. So that's my presentation. And if you have any questions,
and thank you very much.
Please let me know. And I'm going to click off my microphone.
Questions about certification, but I think we'll carry on with Nancy. And then we'll have questions on our wiki at the end so that they can be answered. So welcome, Nancy, and I'm going to get off.
Okay, thank you very much. I would ask that all of you put your seatbelts on, because I will go through these very, very quickly and be respectful of your time. I have included in these, in my PowerPoint slide, a lot of different web links that you can, if you want to find out more information. But both Kathy and Chris have talked about the SCAS, Health Education, the Health Education Assessment Project, and SCAS means State Collaborative on Assessment and Student Standards. We have for many content areas and many issues for CCSSO, but the Health Education Assessment Project is specific for, obviously, health education. We do a lot of training, and here what you see in our first thing is the idea that we have to align curriculum instruction and assessment in order to move, to get the evidence that actually we are improving teaching and learning. Let's see. We have there are issues related to the differences between the goals of public health and public education. We created this slide to begin the conversation about that. In many instances in our states and our schools, we are funded by public health. And so the idea that the accountability systems are different. We are accountable in education for knowledge and skills. They're in public health, mortality and morbidity. To tell you a little bit about the collaborative of states, Maine used to be part of the collaborative. People can come in and out. States can come in and out. South Carolina has been in the project for several years now. We're right now, at the present time, a collaborative of 19 states and 3 large education agencies, including the Department of Defense. Education activities where, for military education agencies across the world. They work together, our group works together to develop assessment and professional development resources. The people who joined, the organizations that joined, they pay participation fees, and so that's how this project is funded. And but in the past, in the beginning, we've had considerable funding through the CDC, Centers for Disease Control. As you can see, the focus is to modify the way the teachers teach. Koji had talked about the classroom climate. We would like teachers to adopt a skill-based, standards-based instructional practice in order to foster student acquisition of skills that lead to health literacy. The goal for CCSSO is to provide product, services, and networking to members to build their capacity to develop effective state training structures. Chris talked a little bit about that. Document implementation, which is, of course, what Kathy was talking about, and to improve health and assessment and technology literacy of the members, educators, and students. Because there's several definitions of health literacy across the globe, this is the one that we used. It's the capacity of individuals to obtain, interpret, and understand basic health information and services, and the competence to use them. So such information in ways that are health enhancing. This is the definition that the Joint Committee on Health Education Standards adopted in 1995, and it was the foundation for the United States Health Education Standards. Okay, we have a lot of graphics because we support our members in training. We have a lot of graphics. This is a graphic that we think really helps, certainly in training and in the classroom, to have an understanding that if you just teach health information, just provide health information, you're going to have a low level of health literacy skills, or health literacy. But it has to be on the foundation of skills. Our project has developed this that gives the logos and for the different kinds of health, for the health standards. And so we have accessing and analyzing valid sources of information. We have analyzing influences, decision making, goal setting, interpersonal communication as it relates to your health, and providing and accessing health care. Self-management is a high level, and advocacy, of course. So we developed a bank of assessment items that, and we decided with our technical advisory group to have 9 content areas. And so it's alcohol and other drugs, injury prevention, nutrition, physical activity, family life and sexuality, tobacco, mental health, personal and consumer health, and then community and environmental health. That was the foundation for all the products and services that we have. This gives you, this slide gives you an idea of the extent of the products and services, or the products that we've developed. When I said what we did, this project in the foundation phase gathered a lot of information, decided we were going to be foundation of everything that we did was the National Health Standards. The assessment framework that you see right here is a framework that we use to develop all the assessment items that we had. Elementary, middle, high school, and the 9 content area. In each one of those content areas were linked, the core concepts within those content area were linked to skills that seemed like the logical link, and then we developed modules of assessment items for that. That was the development, the foundation phase. This was the end of the foundation phase. Then we developed assessment items based on that, and then we went to here, which was the implementation phase, where we developed a lot of professional development materials for all the members. This includes the health literacy posters. There's a lot of posters. If you're interested in finding out more about it, I gave you the link, which is to our distributor of our products. The last little thing, the newest products that we have are right here, which are aligning health and reading with a heap of books, because we recognize the link between health literacy and reading literacy is very strong. We also have this, which is assessment tools for school health education, which our members are using within their state training programs, and also in higher ed in the methods course, in order to move them to align pre-service and in-service. Let's see, the next thing. We have a lot of, we have 4 kinds of assessment items: selected response, short answers, extended response, and performance tasks. But this tells you how we are scoring our student work. We score them based on holistic rubrics for content and skills on a scale of 1 to 4. And then what we do is we only have 1 for core concepts, and then we give guides in our rubrics for the key criteria for looking at sophistication of cognitive complexity levels within these core concepts. We also have a rubric for all of our skills. It's the same one, but we provide skill cues with each one of the skill standards rubrics. Okay. We took when you saw the products that we have, we've taken almost all of our products and now put them on a web-based system. Chris talked a little bit about Metalogic. That is the company that has helped us, and they are wonderful. And I have provided you with information on how their technology has moved us forward. We had, from our item bank, that we had just of our items, we now have a searchable item bank of 1,900 assessment items, elementary, middle, and high school, the 4 types I told you. Teachers can download it for just a paper and pencil test, but we also have online testing of students. The next things we have: the item development tool, cognitive complexity sets, health and reading component, and our media library are all in draft form, but we're really moving forward in this. We recognize that in the cognitive complexity sets that we're working on right now to help members and trained teachers to produce more cognitively complex assessments that we can then have in our item development tool, we must have a professional development component first. We also have, in our implementation phase, we developed all sorts of distance learning course, and we have 6 modules that that can be adapted by members. This is also helping us to align pre-service and in-service in health education. And we can add it very easily, add more modules, which we will probably do in the next 2. I wanted to give you the assessment. Here is a link to our assessment system. It houses the bank. I told you all this information. It provides immediate feedback for students and data for analysis by teachers. It's really great. And our assessment items are for members only, but we have guest access available to browse the system. So if you want to access it through this link, you can. And if you have any questions, please feel free to contact me. This is the kind of information that you can get. You don't have to manipulate anything. You can just ask for it, and this is the kind of thing that you get. This is pretty simple, but here's a pre-test, post-test. Here were the differences, and you can set any parameters that you want as far as what variables you want to see. The next thing, this gives you something that teachers have now done. You know, we have a lot of data that researchers can use, but this system can actually help teachers to use data in order to design and to improve their instruction. This gives you a chart that says accessing information, advocacy, decision-making, interpersonal communication, self-management, and core concepts. A small group of teachers in a district in South Dakota decided to take their injury prevention curricula, and then they did a pre-test and they wanted to see what the skills were. Based on this information, they recognized that students did not have a very good and they were lower in accessing and analyzing valid sources of information. What they ended up doing is then talking together about how they would improve the skill building of accessing and analyzing valid sources of information. The post-test then shows you that pre-test, post-test, and they did have a degree of change that was pretty significant as far as accessing and analyzing valid sources of information. And as we are beginning to recognize, teachers really don't know though that how to do the process of the skills, how to teach the process of the skills, and how important accessing and analyzing valid sources of information is to the development of health literacy in students. So here's our lessons. It takes a long time to get to the teachers. Our project has been in since 1993, and I think it's just in the last 5 years that we really have impacted in getting this into the hands of the teachers. It's important to train teachers to understand the essence. I told you that. Collaboration and implementation would be effective if member teams included teachers and higher ed faculties from research facilities. We have teams of state people who come, but we don't, when they bring teachers or higher ed faculty is when we actually have the most effective implementation. I think as a group we need to come to consensus on the purpose and goal of school health education, because I think it's been really confused with the purpose of public health. And as health advocates we need to support reading literacy because it goes hand in hand. Whoa, I guess. Thank you. Here's what we could, opportunities to move forward in a school setting is to translate public health goals into school health goals, understand the school reform initiatives that are important to educators. I will say I would love to have a discussion on the opportunities that we have when we're talking about 21st century skills and all the other media literacies and career cluster restructuring of the school day that we could really take advantage of, and to involve teachers, key educators, and researchers from the very beginning. And my last thing is that the HEAP is a national program in need of researchers. We have dissemination experiences that could help others. We have technology, and our technology is wonderful, that makes assessment, development, and field testing easier and more cost effective. And we can now, we really have spent a lot of our the last several years to put us in a good position to conduct research cost effectively. And then of course we have the education contacts within us in the states to actually be part of a big research project should we be able to have that funded. And we want to be a part of a team that searches for the deeper meaning of health literacy to translate that into effective programming for kids. And that's it. Thank you for staying to the end.
Thank you so much, Nancy. And I'm going to ask Doug to leap in now. It's hard to, there was so much information today that I think we could have had everybody with their own presentation. And I have been keeping track of all of the questions, and they will be going up on our wiki site. And there's other folks that are writing questions. I will have them all recorded so that we do respond to them from the individual speakers. But Doug, I'm going to go off the audio and go over to you, please, for your comments.
Thank you, Dawn, and thank you to all of our speakers who overcame our initial slow start with the Plan B from COGI. and have managed to finish almost, well, within about 20 minutes of our planned finish time. However, it's my fault for not recognizing that we needed some more time for discussion. So we're going to have to shift that to our web-based wiki that allows us to have that conversation by email, and to be able to let people get on with their respective work days. But I wanted to comment on the overview of this. As people know, we're trying to look at monitoring and reporting in school health promotion, and one of the biggest gaps, of course, is in the area of health education. We saw today a state that has done it well. We saw another state that is doing it well, and we saw a program that enables states or governments to do it well. And then we heard initially from COGI saying that education decision makers are indeed interested in this. They've begun to inquire. They're coming at it from an educational perspective rather than a health perspective, but that's probably a very good thing. And so this overall webinar, I think, has demonstrated that this indeed can be done. Our next step, which is to take all of our webinars from this, and there'll be other presentations in the weeks to come, we'll be preparing a report that will have the presentations linked into it, and that report will be posted on the wiki and allow us to comment on it and to move it forward. And based on the presentations today, I think we can safely say that monitoring and reporting in health education is a doable deed if there is professional and political and practical willpower to get it done. I'm very hopeful that this project can demonstrate that to governments and to practitioners and to researchers around the world. So thank you very much to our speakers. We will be posting the links to the web pages. There are other materials on the web pages as well within the wiki. And I do want to comment on the participants. We had 11 today. We have actually over 30 people signed up for this, and I think what we're seeing is people taking advantage of the technology to access the digital recordings of the web rather than coming on at some extreme hours as we go around the world in terms of time zones. We do know that people are accessing it. They are signing up for the wiki, and so we'll have to do part of this shift onto the web. So please don't be discouraged by the 10 or 11 who are on today. There are actually 30 or 40 people who will see this eventually on their own time, which is the convenience of the web, and will then use the information accordingly. And I will invite your participation in the development of this overall report. So Don, once again, thank you for your very skillful handling of a Plan B. I think the rest of the technology seemed to work well, as it has in the Canadian stuff that we've been doing. So we are overcoming incredible distances. The last session we had people from India and Australia, as well as North America and Europe, and so I'm very pleased that the technology is helping us have this conversation around the world. So once again, many thanks to all of our presenters, and we'll be in touch on the web. And Dawn, back to you.
Thank you. And so I've got a few more questions and comments, and so please type them in if you have time. Thank you, Tamara, for clapping. You can see up at the top that there's a little hand that you can clap, which I'm going to clap my hand for the presenters too. Thank you, and send a happy face. And so be sure to take the time to either type in questions, or when we send you the wiki link within the next day, there will be a spot where you can access the questions, ask more questions, and we'll ask folks to answer them from their own presentations. So to exit our presentation today, you go up to the file. Thank you, Sherry. Go up to the file at the very top, and then if you open that drop-down box, you will see exit, and that gets you out of this School Health Webinars meeting room. So thank you, everyone, so much.
people do have the time to stay on, we can stay on for a while, and if the speakers have time, let's continue this on an informal basis, but also give permission for those who have to go to their next meeting to do so. So, Dawn, I don't know whether you wanted to allow people to, the speakers, there are some questions within the chat box. If people want to respond to those verbally, that would be another option as well.
Yes, great. I'll just go up the chat box and mention some of the questions that came in. One of the questions from Tamara was, what options have you identified to address the issue of non-certified health educators? And Sherry had asked, did I hear this correctly, no teachers are certified in health education? And I think that those were questions for Chris, is that correct? Or was that for Kathy?
That was for Chris, because our teachers in Maine are certified to teach health education.
Okay, and Chris isn't here with us. We've lost her because she had to leave. So I'll make sure that I send those on to her. Thank you, Kathy. There was a question about, since girls score higher than boys consistently, how can health programs be designed to get to both genders at the same time? I don't know if Nancy, Kathy, or Doug want to respond to that. I'll make some comments as well.
I'll just respond. This is Kathy. We didn't really have an answer. It was something that we were just starting to look at as far as how do we engage boys, so that what topics will help engage them, and it certainly is an area that needs to have more research and to be addressed, because it is alarming that our boys aren't learning the knowledge and skills as well as the girls.
I will also, I think in looking at this a little further, all the studies that have shown that if a man is married, that he has a longer life. And the idea is it that females are responsible for health care, for accessing health care and for making the decisions on health care. And so I think it is an area of study I think would be helpful all the way up the line. Or the lifespan. I'll just make a comment. I'm in a school district that has done a fair amount of work trying to bring teachers into the research on gender. And what changed for researchers was in the 90s when they began to be able to use MRI, study the brain in action, and begin to see which parts of the brain lit up when males were doing certain tasks and when females were doing certain tasks. And so I'm sure that you have had some of the background on that, but for sure what it means to us as classroom teachers and the teachers that I work with is having multiple pathways for information to be shared, just to start at that level where how girls learn and how boys learn is quite differently. And then I think your point, Nancy, which is a much wider issue with who's taking responsibility for our health. And again, the fact that there are gender issues there. So yes, we'll get some comments as well from Chris on that. Question from Sherry. Is the Council of Chief State School Officers, I guess this would be you to respond, Nancy or Doug, is it the same as the Canadian CMEC?
Yeah, I think I can answer that one. It is. There is a subcommittee of the Council of Ministers of Education Canada. It's called the Advisory Committee of Deputy Ministers, and that would be, I think, the equivalent of the Chief State School Officers. Those are our CEO positions or Deputy Minister positions, I think.
That's correct. CCSs are the Council of Chief State School Officers. is the professional organizations for the state superintendents of schools, responsible for elementary and secondary education across the United States. So it's once again, it's a member organization, but almost every state has joined, every chief has joined, and so we do a lot of advocacy, leadership, and services to the state superintendent of schools. And then what I just shared with you with the Health Education Project is one example of the kinds of leadership, advocacy, and services that we provide.
Sorry, Nancy, I hit the slide. Were you going back to show us your slide? They do work still.
No, not really. I didn't need to do that. Thanks.
Maybe an addition to that, at the international level, there is no equivalent within the education ministries or ministers or departments of education to WHO to some extent. UNESCO does have education and science and cultural organizations, but doesn't necessarily, there isn't a gathering of the education decision makers around the world that we can go directly to as we can with the World Health Organization. That's why OECD, the Organization for Economic and Cooperation and Development, is very important, very influential for education decision makers for developed countries, for higher income countries. The 30 countries that do belong are, that's one of the mechanisms they use. So I was really pleased to hear this morning that they're continuing to be interested in the social outcomes of learning, because that provides a little bit of a lever. There are other regional groupings similar to OECD. There's a Southeast Asian Education Ministers Group and so on. But there isn't an easy accessible international group, and so we'll follow up with OECD and try to engage the parts of UNESCO that relate to try to get a worldwide dialogue going on this need for better monitoring and reporting and sharing of knowledge. The U.S. examples, I think, demonstrated this morning that it can be done and should be done, and that there are a variety of tools available. I was particularly also impressed with the study of teaching practice. I know in Canada, the only study I've seen of the actual practice of teaching was done in Saskatchewan, and that was like 15 years ago. We do have equivalents of the School Health Policy and Program Survey, which we learned about at the other presentation, the earlier presentation, but it's not going into the depth that we learned about today. And so that's another thing that needs to be done more often, is understanding the constraints and the concerns and the true teaching practices of teachers, so we can design curricula in a way that enables them to do their job more effectively. So congratulations to that bit as well. And if there's a way of getting a hold of that study, that would be really good to be able to circulate. If it's been published or articles on it have been published, that'd be great. So I think, as I say, there's a wealth of knowledge here around health education that we need to move forward to a higher level to get decision makers interested in it.
Okay, and if there's not any other comments, I think, Doug, I will turn off the recording. It's going to be quite a long recording. And then if there's any other last comments that any of you want to make, thank you.
Just again, many
and then I'm going to welcome people. It's the top of the hour, and I think there are probably another 10 people who have signed in, but I know some are working with students. A lot of counselors, school counselors, have registered for this and might not be able to get away, and because this is taped and archived, they will be able to listen to it later. So first of all, welcome to our School Health webinar this morning with Dr. Stan Kuchar from Dalhousie University. And just before we begin, we were just chatting about the special inaugural day in the South, and I hope some of you were able to see some of that and hear Obama's speech, but I'm sure it will be run again so that you can see it. It's a very exciting time. And I was telling Stan, my husband, who's quite a bit older than I am, remembers so much of the 60s and was certainly weepy just watching today. So very exciting time. So that's good to have positive things happening. And this is a very positive thing, having Dr. Kuchar with us today, and he's going to talk about the work he's done with his suicide risk prevention assessment. And I mentioned to several people that we have had Stan speak in the past, and so I have several presentations by him. One had to do with the secondary school program. He worked with Catherine Walensky on a presentation, and another one was on youth and depression. And I know some of the secondary counselors from my own school district took part in that and found it very, very helpful. So Stan, I can't thank you enough for taking your time. The work you're doing with us is just so helpful. We appreciate it so much. And last time he presented, it was in the middle of a snowstorm in Halifax. The power went out, the screen blackened, Stan was gone. I had his PowerPoint, but no Stan, couldn't hear him. And then the phone line was dead, so then he got on his cell phone, phoned back into the webinar, presented in the dark. He'd run off his slides, and so we got through it. So he does go above and beyond the call of duty. So maybe that's why you had your glass of scotch this morning, or this afternoon.
Well,
anyway,
absolutely.
Today we have participants registered from Saskatchewan, as well as Ontario, and as well as BC, a number of BC folks. And as I said, a number are school counselors, and some will be watching the archived version, which will be ready later in the day. Be aware that the audio is different this year because it's coming through your computer. It's a large size of download associated with this software, and so there may be times when there's a gap and the sound either slows down or stops, and then it speeds up really, really quick, and it sounds a bit like a helium voice. It doesn't happen very often, so don't panic. There's nothing wrong. It just has to do with the fact that we're using the voiceover through the computer. Because we can't have multiple speakers on, and I'm going to get off in just a minute, just so that we hear only Stan's voice, we're unable to have verbal chat or questioning, so we do use the chat box a lot. And I will get you, if you have questions, to put them into the chat box. I will keep track. I think Stan will welcome questions along the way, and we expect to have time for questions at the end. The webinar will take about 50 minutes in length, and I know sort of like everything you need to know about youth suicide, it's hard for Stan to compact it so quickly, but he certainly will give us a good overview, and he's always ready and willing to kind of respond to questions. And we will have a wiki toolbox that I know Cindy Andrew will speak of at the very end, where you can go back, find out where his website is, where the information is. So there'll be resources following this presentation today. And I'm just going to say a few little things about Stan himself and his background. He's an internationally renowned expert in the area of adolescent mental health. He's a national and international leader in mental health research, advocacy, training, policy, and health services. So he's done research, he's done writing, he's done a lot of hands-on groundwork. He has served most recently as Associate Dean of International Medical Development for Development and Research with Dalhousie's Faculty of Medicine. He's been named many honors. I have a whole sheet of them, but I'm just going to mention 3. In 2003, he was the top innovator in Atlantic Canada, and welcome folks that are just joining us. We're just getting started, and I'm introducing Stan Kuchar. Stan's work involves translating mental health research into good clinical care as well as patient empowerment. He's written a number of innovative health training programs and is the author of over 200 scientific papers. And what I was going to say, besides being named the top innovator in Atlantic Canada, in 2004 he was named as the National Champion of Mental Health Research, and most recently in 2008 he was named Best Doctor in Canada. And I mention that particularly because I picked up Chatelaine magazine in the fall at my hairdresser's, and there was something on the cover about mental health, youth, depression, and the fact that they had 3 renowned doctors to speak to this problem. And when I opened it up, of course, Stan Kuchar was one of the 3. So thank you, Stan, for getting your work out there to everybody. I think that is so important. His generosity is very profound, and so it's just you ask him to help and he's here. So I know he's busy, and I just am going to say once again thank you, and I'm going to get off this audio and just let you take over, and I'll be ready to help if you have any questions, Stan, as you go along with the presentation.
Thanks, that would be great. Thanks for the kind words. Can everybody, I assume everybody can hear me. So we'll just start on to the next slide. Maybe we could do this. If there are particular questions that people have as I go through these slides, you could just type them in and then I'll try to respond to them as they come through. So let's start, first of all, about talking about what we mean by adolescence. And our current understanding of the concept of adolescence really is looking at young people between the ages of about 13 and 25, so the 10 or 12 years following the onset of puberty. And that is a construct which is much more consistent with what we know today as normal brain development and in terms of the kind of functions that people go through as they grow and develop. There's a huge mythology around adolescence, and that is that teenagers are supposed to be disturbed, but the reality from all the research that's been done on kids shows that most teenagers pass through those years without severe and prolonged difficulties. Now, that doesn't mean they don't have some difficulties at times, stressors and their responses to stressors, but that's normal, that's perfectly acceptable. In fact, it's necessary, but most of them don't have severe and prolonged difficulties. On the other hand, about 20% will experience a mental disorder or a substantial mental health problem during the adolescent years. And mental illnesses are the most prevalent disorders that onset in adolescence. They're far and above beyond everything else. They really, really have a major, major impact in this group. And I just put the little finger on that part on the slide. 70% of all mental illnesses onset prior to age 25. That's just a huge, huge impact. And if you look at globally, that's across the entire world, mental disorders in the adolescent years make up almost 1/3 of the global burden of disease. That means that HIV/AIDS, malaria, tuberculosis, doesn't matter what you put into the mix, mental disorders in this age group contribute about 1/3 of the global burden of disease. In Canada, that contribution is even higher because we don't have many of those kind of infectious diseases that we're just talking about. Now, in young people, suicide is very closely linked to mental disorders, particularly depression. However, we also know that suicide can be influenced by other factors, such as availability of lethal means, social cultural phenomenon, etc. And we'll talk more about this dynamic interplay between mental disorders and suicide and other factors in suicide in young people. Now, this slide, which looks at cross-national comparisons of the onset of psychiatric disorders, actually shows what I've just said, and that is in whatever country people have looked at, we see that the mental disorders here, we're talking about anxiety disorders, more than half of them onset by age 15, so by 25, you're looking at 3/4 of all the anxiety disorders have started. Substance abuse, again, same thing, you see here, and mood disorders, and you're looking at, again, you see the same thing. And you find that for schizophrenia, etc., etc. So that, again, just showing the fact that these disorders, mental disorders, are adolescent onset illnesses, and that they are found across all countries and cultures where they are studied. Same pattern everywhere. Now, before we start talking about the issue of suicide, it's probably a good idea that we all agree on what the words mean. So here's what they are. Suicidal ideation, or suicide ideation, is a term that refers to any thoughts, images, or fantasies of harming or killing oneself. Suicide intent is the conscious decision to take one's life. A suicide plan are those events that are considered or thought through leading to the attempt on one's life. And a suicide attempt is a purposeful, self-inflicted act that is not fatal, but associated with the implicit or explicit intent to die. A completed suicide is exactly that act that is fatal, and self-harm refers to any self-inflicted destructive behaviors not associated with an implicit or explicit intent to die. Now, one of the troubles and problems that we have when we look at suicide or research literature is that in many cases, if not most, self-harm attempts and actual suicide attempts are linked and lumped together under the construct suicide attempt. So here, suicide attempt, it's purposeful, self-inflicted, non-fatal, with the implicit or explicit intent to die, and self-harm is a self-harm or self-destructive behavior not associated with the wish to die. So, for example, cutting or burning that a young person might engage in secondary to an argument with a friend, or a manipulative event like that, would, if that person went to a hospital, be called a suicide attempt, and they're really not. Now, why is this important? It's important because these groups are different. Kids who self-harm without the intent to die are very different than kids who have the intent to die. And the interventions for them is different, and the approaches to them are different. And yet we have this confusion in the literature. And in fact, I'm not sure whether or not the oft-stated construct that girls are 12 times more likely to attempt suicide is really attempting, or whether they are more likely to engage in self-harm. And we're still waiting now for the studies which can help us sort that out. But I just want to raise that as a particular thing to think about. The word suicidality refers to any thoughts or actions associated with this implicit or explicit intent to die. And I'd actually like to see us strike the word suicidality from our lexicon, because we really have no idea what someone is talking about when they use the word suicidality. And it makes a big difference if you're looking at suicidal ideation, and studies show that 30% of a teenage population will have some ideas of suicide over the course of a year, and suicide, which is 0.01% of the population. So they mean very, very different things. Now, it's also important to remember that teen suicide, and suicide in general, is a highly emotional issue. And when we talk about risk, we have two issues that we need to consider. One is what we call the hazard, which is the mathematical calculation of the likelihood or probability of something happening. And then the other thing is what we call the outrage, which is the affective component associated with that problem. So, for example, people get much more concerned about dying when they're being eaten by a shark because of the outrage or emotional impact that has than they would about dying from being hit on the head by a coconut, which you're 100 times more likely to die from being hit by a coconut than you are by being eaten by a shark. And yet nobody makes movies called Attack of the Coconuts. And it's because sharks are frightening and coconuts, frankly, are not. Now, this is a statistic which is very common and often misunderstood. And this is the percentage of all deaths due to suicide by age and sex. And this is Canadian data. And this is where the statement comes from that suicide is the second or third leading cause of death in young people in Canada. And if you actually look at this graph, what you find is that, yes, indeed, if you look by age, that suicide is actually fairly common as a cause of death in this group and in this group, and it tails off in these groups. When I show this slide in our training programs and ask people what it means, most people say, well, that means that suicide is more common in young people. Well, nothing could be further from the truth. What this slide tells us is that suicide is a common cause of death in young people. Why? Not because suicide is so common in young people, but because the other causes of death are so rare. So as we come out further here into the older ages, we find that the proportion of deaths due to suicide goes way down, but the numbers may be about the same because the other causes of death are so much higher. Now, when we look at the rates of suicides per 100,000 by age group, we see this particular pattern which we find in many Western countries. Suicide prior to puberty is quite rare. The rate increases dramatically over those 10-15 years after puberty, consistent with the rise in mental disorders. And then it continues to rise. The highest rate of suicide is not amongst young people. It's actually amongst middle-aged men. So the highest risk group for suicide is men between the ages of 35 and 60. That's the big window for suicide prevention, but that doesn't mean we need to ignore the youth, because this is when the curve really starts to go up. So you see that this data, this was over 4 years in Canada, shows remarkable consistency in this age pattern, and you see this kind of consistency in most places in the Western world that you actually look. Now this again is this same data, but it's plotted in a different way. Instead of looking at an age standardized graph, what we're looking at is a province by province analysis of the rates. And what you see when you look at this is something very interesting. First of all, you see that from province to province, there are tremendous differences in rates amongst the provinces. So here is Quebec with a rate of about 16 or 17 per 100,000, and Newfoundland with a rate of about 6 per 100,000. So you have almost a threefold variation in the rate from one province to another. Well, here's New Brunswick. And New Brunswick is like right next to Quebec, and it has a rate of about 10 per 100,000, and Quebec is 16 or 17 per 100,000. So you see this tremendous difference in rates province by province. When you look at our First Nations communities, you see very, very high rates in First Nations, and this is Inuit community, and it's not low, it's actually really, really high. It's per 10,000, so that if you were actually to plot it on the same scale, the rate would be just off the map. So you see in Canada tremendous variability in rates, suicide rates amongst the different provinces. So you know right away that mental disorders probably don't vary that greatly from province to province. So there has to be some other factors at play in different locations which will explain suicide rates. And actually when we look, and this is interesting data from Canadian sources, looking at the differences in suicide, and this is called suicidality, which wasn't my term, it was Dr. Chung's and Dua's term, but it meant suicide attempts and completed suicide. And they took Ontario as 1. So Ontario doesn't appear here. It's given a score of 1. And then they compare the other regions of the country to Ontario. So below 1 is less than Ontario, and above 1 is more than Ontario. And you see here that the Atlantic provinces, this is where I live, we come in, it's less depression and less suicide than Ontario. Quebec, more depression and slightly more suicide. The Prairies, less depression, but, a lot more suicide. British Columbia, a little bit, and a fair bit higher than Ontario. Again, reflecting that in youth suicide across the country, there are differences in how young people rate in terms of suicide ideas, suicide attempts, and suicide period, and rates of potential depression, although these are not anywhere near as variable as these. Now, one of the interesting things that you see here is that, contrary to what many people believe, suicide in young people is not increasing. In fact, between the early 1990s and about 2003, 2004, the suicide rate has actually decreased substantially. And this is American data, but we see the same in other places, that there were indeed increases in the suicide rates in young people over the decade of the 1970s to the late 70s to the 80s. So this decade saw about a 20% increase in suicide rates. And then from about the 80s to the mid-90s, the rates leveled off and stayed fairly consistent all the way along that time. And then they took a major nosedive and dropped dramatically over the next decade. Why this is, we have absolutely no idea. What we do know is it is not related to all sorts of things that we would hope it would be related to, such as public health interventions and suicide intervention programs. This just seems to happen by itself. There are obviously factors here, but we don't know what those factors are. One of the factors which has been suggested is the increased identification and treatment of depression in young people using SSRI medications as a surrogate marker for that, because at the same time that this happened, you found that the increase in SSRI treatment for depression went way, way up. Now, one of the sad things that this slide doesn't show us is that between 2003 and 2004, the rates have started to climb again. And again, this is correlated to decreases in SSRI treatment after the FDA black box warning about these medicines, and you find exactly the same thing happen in Canada. That doesn't mean it's a causal mechanism. It's an interesting ecological relationship, but I just suffice to say that suicide rates go up and down, and why they go up and down in particular ways sometimes are incredibly complex and difficult to figure out. Now I'll just show you the same data for Canada, and this is overall data dropping down, and this is youth data also dropping down. And we just finished an analysis of the rates in Nova Scotia. You see exactly the same pattern in this province. I don't know if it's the exact same pattern for every single province, but certainly across the country we've seen this gradual decrease in suicide rates from an average of about 17 per 100,000 in 1979 to about, what's that, 12 per 100,000, so about a 20% drop, which is quite significant. Now, interestingly enough, if you look at here the prepubertal rates, the sort of young kids, they stay pretty well consistent year after year after year. So what does this actually mean to us? It means that suicide is a very complex issue. And there are no simple answers to suicide, and if people tell you that they know the simple answer, they're most likely speaking through their hat. We have variable rates across different locations. The same factors may not be at play in all locations. So you must know the factors associated with suicide in your location. So suicide is a local issue with general components of mental illness, and that causes us to be exceedingly careful with explanations for the causes of suicide. Let me show you what I mean. Here is one of the common explanations of suicide. In young people, it's because they're young and stressed, and this, unfortunately, is from the Canadian Mental Health Association website. They talk about adolescence being a dramatic time of change. Young people feel pressure to succeed at school. They feel pressure to succeed at home and in social groups. They lack life experiences, and so these factors become such a source of pain they seek relief from suicide. This is just absolutely not correct. First of all, the highest rates of suicide are not in young people. It's in men ages 35 to 55. And because kids feel pressure to succeed in school or at home or in social groups does not lead them to suicide. Every single teenager feels pressure to succeed at school, at home, and in social groups, and every single teenager lacks life experience, but the number of teenagers that commit suicide is very, 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 very small. So this kind of explanation is just not only is not correct, but it actually takes attention away from those factors which actually are important. And this is not just, here's from the Canadian Red Cross, and this tells us that unlike adults, youth do not have the ability to think about life in a broader perspective. They believe unhappiness is forever, and because of these difficulties, trouble at home, change of schools, being bullied at school, breakup of a relationship, dating, for crying out loud, that leads kids to commit suicide. This is really, frankly, in my opinion, irresponsible. Now, the other thing that this does, again, it talks about not have the ability to think about life in life terms in the broader perspective, and that the largest group at risk for suicide are not teenagers, they are actually middle-aged men. And here is another nice explanation. It's in the Canadian Children's Rights Council. They are very clear that rates have tripled, and of course they neglect to note that the rates have been going down. But they say here, the most important explanatory variable is the increased share of youths living in homes with a divorced parent. So which is completely nonsense. Yet, can you imagine what kind of stigma that gives to someone who happens to be a divorced parent whose child commits suicide if they read this kind of drivel? Now, one of the big things that we have to come to terms with and grapple with is this concept of risk factors, because every time you talk about suicide, you hear people talking about risk factors. So it's really useful to say, well, actually, what is a risk factor? Well, you know, it's not as simple as it is. The first thing we have to say is that risk factors are not causal. So because something is called a risk factor, that doesn't mean it causes anything. So a risk factor, if it's present, increases the probability of an outcome. So a risk factor is a correlate and actually may have nothing to do with causality. For example, you can think that being female is a risk factor for being pregnant. Clearly it's a risk factor. Does being female cause you to be pregnant? As far as we know, no. Risk factors have different strengths of effect, and we measure those strengths by statistical calculations called effect sizes and odd ratios, and not all risk factors are similarly impactful. So if you have a list of 25 risk factors, yes, all those things may have been correlated with a particular outcome, but the strength of impact or the strength of the correlation may vary dramatically from one factor to another, and yet they still all would be called risk factors. And yet, if they have any impact on causality, their impact may vary hugely. So not all risk factors are alike in terms of their impact. The other important thing to remember is that risk factors may not exert their effect independently. So that means that just because something is a risk factor doesn't mean that it exerts an effect on the outcome by itself. It may only operate in the context of another risk factor. So, for example, being female is a risk factor for being pregnant, but that risk factor only operates in the context of another risk factor, ergo the presence of sperm. So if we actually take that analogy, which is an interesting analogy, you can also argue that dim lights, chocolate, a good glass of wine, soft music are also risk factors for pregnancy. But soft music and chocolate and wine as a straight impactful risk factor would be much, much less than one of the other factors. Now you can start thinking about, if I'm going to use a risk factor approach to prevention of pregnancy, should I actually target no chocolate, no wine, and no music? Unlikely to be a useful intervention for preventing pregnancy. The next question is, what is the difference between a trigger factor or precipitant and a risk factor? So if we know, for example, that a number of young people may have had an argument with a parent or a friend before they commit suicide, does that mean that arguing with a friend or with a parent is a risk factor for suicide? Or does that mean that it was an event that actually led to a particular behavior and it's not a risk factor but a trigger or a precipitant? So risk factor thinking gets a little bit muddy around those particular concepts if you actually try to pull out, is it a trigger factor, is it a precipitant, and how does that actually differ from a risk factor? So why am I talking about this? It's because that it is very common in discourse around suicide to talk about risk factors for suicide. It's one of the ways that we address suicide prevention, by addressing risk factors. And yet the question of what a risk factor is and what it actually means is not necessarily as clear as you would like it to be. So if we want to use risk factors as a method of preventing something, what we would really need to do is we would really like to focus our attention on risk factors that we can modify and risk factors which are likely to be causal. So the area that we really want to focus on when we want to do risk factor-based prevention is in this box here. So a risk factor which is likely causal and modifiable. We really don't want to focus our attention on risk factors which are unlikely to be causal or completely not modifiable. So for example, going back to our pregnancy risk factor phenomenon, being female is potentially causal for pregnancy, but being female is not a very modifiable phenomenon. So when you're thinking or reading about risk factors in suicide prevention, I think this kind of chart would be a reasonable one to keep in mind. Look at it against every risk factor that you see and say, is it causal? Is it modifiable? If it is, maybe the program should address that. If it's over here, or over here, or over here, what is the value of the program addressing that factor likely to be? So some of the things that we know that are moderately to strong risk factors, some may be causal, or they're highly, highly related for risk factors in suicide in young people. The top one is mental illness, especially major depressive disorder. And the various studies that have been done on this show that the odds ratio, that means the strength of the impact, is between 11 and 27 times greater than not having a major depression. So that is a really huge factor pertaining to suicide in young people. And frankly, if there's a one take-home message from this, it's that the presence of depression in a young person substantively increases the risk for suicide. And if you really want to address suicide issues in young people, you've got to address the issue of depression. Substance abuse increases that risk. possibly because of its impact on impulsivity, the presence of a prior suicide attempt, especially in males. Remember, females may attempt more often, so if a male has attempted, they're much more likely to die with a subsequent attempt. Having a family history of suicide or a family history of suicide attempts increases the risk substantially. If there's a family history of suicide in the mother, the risk is 5 times greater than if there is no history, and if the father has suicided, the risk is 2 times greater. A really interesting phenomenon which has recently been uncovered is that the question is where geographically or locationally or organizationally are kids at greatest risk for suicide. And if you actually look at where they are, the kids in the juvenile justice system are at much, much, much higher risk for suicide than kids who are actually in the regular educational system. These are very often identified as being risk factors for suicide. And you just have a look at these. There is really very, very little substantive evidence that any of these are causal. And if they are related, they are very, very weakly related to suicide. Now, when we're dealing with suicide prevention, it's really, really important that we are able to evaluate what we do and that we know what we do. And we can evaluate suicide prevention programs as to their effectiveness and cost effectiveness. We can use well-validated scientific and statistical approaches for every single method that we're using. We have to make sure that our studies are properly designed and properly evaluated, and there are a host of big problems with the current literature on prevention of adolescent suicide. Poor study designs, the use of proxy outcome measures, meaning that instead of measuring completed suicide, they measure whether or not a person knows something about suicide or doesn't know something about suicide. Inadequate follow-up times, they haven't followed the sample long enough to determine whether it's going to make an impact. Something we call provider-evaluator conflict, that is that the person that created the program studies the program, and then you're very surprised to see that it's a positive outcome, and confounding effects of secular trends. We've just seen that, for example, between 1990 and 2005, suicide rates dropped substantively. Now, if you have a program that's going on at that same time, you have no idea whether the drop in rates is because of the program or because it was just changing that way anyway. And so that's a big problem in the research. And we do have very clear criteria that we can use to certify programs as being effective. And these are the criteria that are being used globally, and it comes from the U.S. federal collaboration on what works. So these have been well sorted out, and any program can be analyzed against these criteria. Now, our group has just finished analyzing all the global research on school-based suicide prevention programs, and what we find is that we can't identify that any program has actually proven to be effective. No program has even proven to be promising. One program, the SOS program, suggests that with some more research it may become promising, but at this point we don't have a suicide prevention program that we can say actually works in schools. So what have we got in terms of, as of this month, what does the data tell us about things that can prevent or potentially prevent suicide in young people? What we do have is our studies which show that early diagnosis and effective treatment of mental disorders, particularly depression, in primary care and in mental health care actually work, that restriction of lethal means, that such as bridge barriers, gun control, pesticides in other parts of the world, not so much here, work. And early, now this is really promising, which is pretty neat, and some of this can happen in schools, early identification of youth who are suffering from mental disorders and youth who are suicidal. And that is gatekeeper training programs can be applied in institutional and organizational settings, and there is some data to suggest that they may actually be helpful. Not necessarily as preventing suicide, but getting young people who are suffering from mental disorders and youth who are suicidal into care as quickly as possible, or into intervention and treatment as quickly as possible. Now, when we are dealing with the issue of suicide prevention and prediction, it's an inexact science, and one of the problems that we have is that no matter how careful we are and how hard we try, we just can't predict the future. And there is a duration issue. As a trained clinician, I have a reasonably good level of comfort of being able to predict the probability of an imminent suicide attempt if I see someone in the emergency room. So I can say, you know, I can figure out that over the next 24 hours this person has this probability of committing suicide. When we're down to 2 weeks, you know, I can't guess so well. And if we're looking at a year down the road, I'm completely unable to predict who will or who will not commit suicide. So that's a big problem, is the duration issue. The other issue is that most people who are suicidal don't die by suicide. In fact, it is the minority of people who are suicidal who actually die by suicide. A corollary of that is that some people who die by suicide will never disclose suicide intent. And so we know that evaluation of risk does not make prediction infallible. We do the best we can with the information that we have, but we can't think that we're going to be infallible. One topic that comes up, which is often avoided, is this particular one. We know that, for example, if you have heart disease, the chances are that you will die of a heart attack, a myocardial infarction. And there is an expected mortality rate from people who have heart disease dying of heart attacks. Now, suicide is a mode of mortality for mental disorders. And so the question that arises is, given that there is a particular population prevalence of mental disorders, what's the expected mode of mortality rate for suicide? Not an easy question to talk about, and certainly a difficult one, a concept that we have to address, but not to think about it would be a bit Pollyanna-ish. And what various people who have looked at this topic have suggested is that somewhere between 4 and 10 per 100,000 seems to be a population base rate of suicide associated with mental disorders. Now, what this means is that if we're seeing population rates in that area, 4 to 10 per 100,000, the focus that we might want to put is really on improving mental health care. If we see rates that are above 10 per 100,000, we have to start looking for some social factors that we may need to address in order to bring down suicide rates. And that simply looking at improving mental health care may not be the appropriate route to go. So these numbers might help us in terms of figuring out where it is that we need to put our big efforts. So for example, if we have a rate of 340 per 100,000, such as in the Inuit population, the chances of that all being due to mental disorders is slim to nil. So we have to look at social factors there, and our suicide intervention programs have to be built on those social factors that can be modified to decrease rates. Whereas in Nova Scotia we have a suicide rate of 4 per 100,000 for adolescents. It's unlikely that there are specific social factors in Nova Scotia that are leading to adolescent suicide, and we have to look more towards health and mental health issues to bring that number down further. So this number doesn't tell us we have to stop or be satisfied with that rate. This number tells us that we have to focus on different areas for suicide prevention. I think that that's a useful way to think about it. Now, there are lots of different approaches that we can use. There is an individual risk approach that can be done within an institution or in a mental health service, such as the Gatekeepers program. And these kind of interventions are useful if people who are in this institution have necessary knowledge and competencies for high-risk identification. They're also then useful if the health providers actually know what they're doing, so that the health providers have the necessary knowledge and competencies for identification, assessment, and treatment. And these approaches, if those other components are found to be in place, actually have demonstrated effectiveness in preventing youth suicide. So one of the things that we look at is what's the individual's risk for the probability of an imminent suicide attempt. And we use risk factor evaluation as a tool to assist in treatment decision making. Now, I have found in our work in this area that if we just simply focus on suicide, we are missing a huge group of kids who could be helped, who could be treated, and who may be at risk for suicide, not today, but 6 months down the road. And by intervening now in a mental disorder or a substantial mental health problem, we can actually potentially decrease suicide risk downstream. And so as we're thinking about this, that we need to be thinking about not just assessing kids for an imminent risk of suicide, but assessing young people for the presence of a mental disorder that may be related to a suicide attempt in the future. So one of the things that we then want to look at are what are the kinds of issues that we might want to identify in young people, say in a school setting. What do we have to look for that would maybe raise our level of suspicion or concern? So one is that has there been a recent, significant, and problematic change in the young person's mood, the young person's cognition, or their behavior? So we're looking for something which is a substantive difference from previously and actually is a significant difference and a problematic one. We're looking to see whether there are decreases in functioning, social functioning, academic functioning, recreational functioning, or others. And these kind of functional problems are highly related to major mental health problems, mostly likely mental disorders. And the other thing is the young person known to have a mental health problem preceding this that may be impacted on it, or is the family known to have mental health problems, including substance abuse? Because these are risk factors for mental disorders and for suicide. So the high-risk student, these are the questions to ask. Is the student's emotion, cognition, or behavior distressing to others? Sometimes you don't find it it's very hard to figure out what is going on, but if you see it distressing to others, that doesn't mean just negatively impacting on others, such as conduct, behavior, disturbance, but a young person was withdrawing, their friends are becoming distressed about their withdrawal. Does the student exhibit a lack of social convention that he or she seems unaware of? Though this is the issue for first onset psychosis, that as the psychosis gradually comes on, because they take months and months and months to come on, we see the observer will identify a lack of social convention, and that the young person who is becoming gradually psychotic will not be aware of it. Are the student's emotions or cognitions or behavior substantially different than those of his or her social cultural peers? And here we have to be very careful that we don't label students' behavior as deviant or problematic because they belong to a social cultural group or a subcultural group that engages in those kind of subcultural behaviors. This is an important one. Are the student's peers or parents concerned about the student's functioning? And here peer concern can really guide the educators in identifying kids who are at risk, and that is if their friends come and say to you, listen, I'm worried about so-and-so, they're not themselves, things aren't going well for them, that's a kid that needs to be paid attention to. We've already talked about this, changes in cognition, and this is a really important one. Has a friend shown substantial problems? You know, birds of a feather flock together, and we'll talk about this a bit later on, and if a young person has had a suicide attempt, their friends are at high risk for mental health problems and high risk for suicide attempts as well. This is not a tool that I would suggest you use in the school setting unless you're a guidance counselor or a psychologist working with kids in this way. This is a tool that we have developed and we're using here in the IWK mental health program for clinicians to evaluate the capacity for suicide risk in kids. If you're interested in finding out more about this tool, you can come to our website, which is www.teenmentalhealth, all one word, teenmentalhealth.org, or you can just Google teen mental health and we'll come up first or second on the list. And you come into the website, you can go to the section for professionals, find the tool, read about it, and if you want to use it, just ask us for permission. We give you permission, but make sure you clear it with your educational institution first. It's actually fairly easy to move from identifying a young person with some distress to asking about suicide, although it does take practice and you have to become pretty good at it and comfortable at it. And there's a three-stage process which goes from empathy to general inquiry to direct inquiry. And the first is empathy. You're trying to here establish a link with the young person. Phrases such as, I can see how difficult things have been for you lately, you seem to be having a hard time. It allows you to establish that empathic feeling connection. Quickly go to, would you help me understand how this has been for you, giving a wider framework for the young person to talk about their problems. And then, if you're concerned, have you ever felt life was not worth living? Have you ever done anything that could have harmed you or killed you? So you move from establishing empathy to actually directly inquiring about suicidality in a high-risk youngster over the course of 3 to 5 minutes once you get practiced at being able to do this. Now, one of the issues that for schools have to think about very carefully is what happens if there is a suicide of a student, and how should the institution respond to that? We know that the rationale or the thinking behind a school's response is that a timely response to a suicide may reduce subsequent morbidity and mortality in fellow students. However, we're now just doing an exhaustive search of the critical incident stress debriefing literature, and we have yet to find one paper or one scientific study which has evaluated this kind of response in a school setting. So if anyone who is listening to this webinar knows of a study, I would love for you to send me that reference, because I have my research assistant is working on this. We've done literature reviews every single way that we can think of, all the usual Cochrane methods, the PubMeds, everything else that we've done. We just cannot find one study anywhere in the world which actually evaluates this kind of response in a school setting, although it's a response model that is used through schools everywhere. We can't find one study that tells us about it. Now, there are other major cautions about this kind of approach, and that is basically your critical incident stress debriefing, your grief counselors from outside the school coming in. And that is that the effectiveness of this kind of intervention, even in other areas in which it has been touted and which it is used substantively, is not good. And in fact, the available research is sparse and often contradictory. Most of the most recent research for this kind of approach shows that such interventions actually, instead of being helpful to people, can be harmful. And the most recent work in the last 2 to 3 years advises against the use of critical incident stress debriefing. So the question that I'm not sure about is, could grief counselors and trauma interveners in schools make matters actually worse for kids? It may be more useful than doing this in a sustained way is to look at what we call the late identification model. In any population in which there's a traumatic event, you have an increase in symptoms in the entire population as part of the acute stress response. This is normal, it's to be expected, and you find it everywhere, regardless of the traumatic event. Now, each organization, community, institution has its own way of dealing with these things substantively, and what happens if you do absolutely nothing? The organizations deal with them as long as there's no repeated trauma, and things eventually get back to normal. But not for everybody. There's a small number of young people who can continue to have difficulties. We say that they're persistently symptomatic. So looking 4 to 6 weeks after a traumatic event, you're able to pick out those kids who aren't habituating to the stress. And those kids are at risk for having mental health problems. And that's when you might want to intervene. You might want to find those kids who are not habituating to the stress of the trauma and identify those kids using those criteria we just talked about and offer them interventions. So a word of caution about all this is that if you're using these programs, they should be based on some good evidence, and if not, they should be very well planned and evaluated to avoid exacerbating problems in students or in staff. So here are some possible issues for you to consider in your own location that may be associated with suicide prevention. One is working to increase diagnosis and access to effective treatment for kids with mental disorders. So that is a really clinical approach, but it's an important one, and we know that it actually works. Early identification capability, such as creating awareness in school personnel and guidance counselors and in teachers, can actually also advance this framework, particularly if the system is responsive. Restriction of common lethal means, gun control, safe storage of poisons, gasolines, etc. We've known works like bridge barriers. We know those things work, and that's a good public health approach to advocate for in your community. Media training, there's some evidence that suggests that media training is helpful, and basically working with the media not to sensationalize reports about suicide. Another public health approach that may be helpful. In the school setting, the birds of a feather flock together model. This has not been tested because we've only become aware of it recently, but it is that kids who hang around with other kids who are suicidal are themselves much more likely to be suicidal. And if we look at studies which look at young people who have committed suicide and look at their peer networks, we find high rates of mental disorder, high rates of suicide attempts, and high rates of suicide ideation. So it could be that these kind of peer networks are the networks which are associated with cluster contagion or copycat suicide. So one of the things that can happen here is if a young person makes a suicide attempt, as a good institutional response could be is to work with the peer network of that youngster, or if a student commits suicide, instead of doing critical incident stress debriefing for the entire school, which may not be helpful and might actually be harmful, identify those youngsters who were friends of the student who committed suicide and work with them. And then this other one, the Gatekeeper Plus model, this is one we're actually piloting now in Nova Scotia. Identifying teachers, giving them skill sets for helping them identify young people with major mental health problems or mental disorders, and linking them with guidance counselors in the school, and then linking those people with mental health services. So this combines individual and public health approaches, and we're just starting the pilot studies, and we're hopefully in a few years to have some data to tell us whether or not it's as effective as we hope it might be. So that comes to the end of our presentation on suicide prevention in the educational setting. We've covered an incredible amount of ground in a very, very short period of time. Hopefully that some of the issues that we raised were thought-provoking and would cause you to read more. You can go on to our website here to find out more information. We have a number of detailed programs that train educators and train health providers in suicide risk assessment and in dealing with depression in young people. And we can open it up for questions at this point in time.
Well, thank you very much, Stan. It's Dawn here, and not only did you cover a lot of material, but you also, and each time I hear you speak, you challenge our commonly held perceptions or misperceptions. So I think there were probably a number of slides here that people were really having to think about because it isn't the way we were aware or wasn't what we were thinking perhaps before we heard you speak. So for sure some of you counselors working with other colleagues may want to have the PowerPoint slides after, and I will send them to you. But right now I'd like to ask if people have some questions, if they could type it into the text box, and I see that there's a question already. What is SOS?
Oh, it's one of the suicide prevention programs, and it's an acronym for the suicide prevention program in the States, and I completely blocked on what it stands for. But you know what? If you just wait 1 sec, I'll yell down the hall to one of my research students, and they'll tell us. Hang on.
And we'll give that and make sure that you have the answer to that. Okay, and it looks like some other folks are typing in some questions as well. I know Stan does occasionally come to BC. Okay. He was at UBC. Okay, thank you, Stan. Over to you.
I have them. It's called Signs of Suicide. It's a special classroom-based suicide program, very popular in American schools. So SOS stands for Signs of Suicide.
Great. And do we have another question? I see some folks are still typing. Stan, can you see? Yes.
Oh, yeah, I got one here. Have you come across research about how social determinant of health has helped? Well, let me be very challenging to this concept of social determinants of health. I just finished reviewing a major literature analysis of this in mental health, and to my dismay, the people that did the literature review didn't apply any of the critical analytic tools that we use to determine whether what is discussed actually meets validity criteria or not. So there's an awful lot written on it, but the amount of good information that we have is very sparse. Now, social determinants social determinants of health are not determinants, they're certainly correlates, and the causality vectors are multiple and complicated because one determinant hides a multitude of other determinants in it. So what the issue here is youth suicide as a health outcome. You know, I don't understand the concept of youth suicide as a health outcome. Certainly we know that there are social factors above and beyond mental disorders which are at play in impacting on youth suicide. And those social factors can range all the way from availability of lethal means. So in communities in which guns are freely available and are often used, you have much higher rates of suicide than in those communities which don't have access to guns. So availability of lethal means is a social factor which is associated with higher rates of suicide. When you decrease the availability of lethal means, you decrease suicide attempts because what you've done, or suicide, because what you've done is you haven't changed the attempt profile, but you changed the lethality of the attempt profile so that people are much less likely to die from the attempt, they're much more likely to survive. So there are multiple factors like this at play everywhere. So there is a frame of reference and numbers, as I said before, from maybe 4 to 10 per 100,000, which are associated with the mental disorders. But on top of that, absolutely, there are lots of cultural and social factors which are associated with successful suicide.
Okay, while we're waiting for anyone else to type in a question, I just had a question, Stan, just back to grassroots, what happens at the school level. Are you suggesting that in the case of a suicide death, that you might not want to have counselors available for everybody in the school, or you might want to try and work with the friends of the person who died from suicide? Is that more what you're thinking about, being more specific?
Well, if we think about this from first principles and critically examine what happens, let's take a school that has 800 students in it, and let's say one of the students suicides. Depending on the profile of that student in the school, we could have students we could have the majority of the students in the school being concerned, or we could have the vast majority of the students being not concerned at all. I mean, it may sound harsh, but you know, that's the reality. In a situation in which you take people who are external to the school, who don't know any of the students, who don't know the school, who don't know the classes, and bring them in and say, okay, now what we'd like you to do is spill your innermost secrets and innermost thoughts to these strangers you've never seen before and who 2 days from now you're never going to see it again. Does that make sense? The other thing is that if you force kids, and this is into assemblies, into discussions, into talking about the issue, into force them into this cathartic framework, we know actually now from very good neuroscience research that what this actually does is it enhances the likelihood of a negative outcome. Because what you're doing are two things. One is you're re-traumatizing the kid over and over again, you're adding to the trauma, and secondly is you're forcing them to remember the trauma. Now, one of the things that we do as a species is we are very good at forgetting trauma, except trauma that contributes to our capacity to survive as a species. We have to remember a few things, but we don't need to remember all the details. The more that we remember the details, the more likely we are to recall those details, and the more likely we are to get post-traumatic stress disorder. So we understand the neurobiology behind this kind of repeated traumatization. We know that it's bad for the brain and for memory. And you see what a lot of this kind of intervention was based on was now well-discredited models of catharsis as a way for dealing with trauma. And those come from Freudian psychoanalysis. They're just not true. They're not valid. And the best way to deal with considered trauma is not catharsis. It's to deal with it in more pragmatic ways. So if I was to advise a school and how to deal with this. I would not advise bringing in grief counselors from outside. What I would advise was having a place available where students could come and talk to each other after school hours with perhaps a teacher or a coach or someone who knows the students and is liked by the students, or a guidance counselor from the school who is liked by the students, and they can use their own healing strengths within their communities to address the particular issues that come up with the schools. What I also would suggest is that teaching teachers 4 to 6 weeks after the event is identifying students who are now showing signs of distress. So those are students who are not able to habituate the acute stress response, and those kids actually would benefit from some counseling. So that would be my response to it.
Great, that's very helpful. I think, Cindy, we're probably just about ready to close, and I will stay on the line for a few minutes after, and certainly if you type in any questions, I will make sure that we get it up on the wiki. But I'm going to turn off my audio, Cindy, and ask that you take over for me.
Well, Dawn, could I just say one thing
on this? Go ahead.
Right now, this question comes up over and over and over again, and so one of the things that we're doing over the next 2 months is we're doing, as I said, a very comprehensive, systematic search of the world literature on this particular issue as it pertains to schools, and we're going to be writing up the results of this analysis and then posting on our website all those results and actually what the literature and data show us, and then giving information that schools can start to think critically about what it is that they're doing and why they're doing it. So hopefully in a month or two, if people want to go back to our website, that information will be available for them.
And that would be very helpful. I'm on a school district that is on the Trans-Canada Highway, and one of the most significant things that seems to happen is death to our students, but not necessarily by suicide through car accidents. It seems we always lose a student or two and sometimes 3 a year, and so just knowing how to deal with that type of a crisis, it sounds like it would be a similar pattern. So Cindy, I'm going to get off and over to you.
Thanks, Dawn, and thank you in particular, Stan, as usual, for I think for enlightening us, and also for in terms of just reminding us of putting suicide within the context of some of the bigger picture, and that whilst clearly it's an issue of concern for many, we can't lose sight of the fact that of what the numbers really show us, and in fact what it begs us all to do in terms of looking at sort of the more upstream mental illness prevention, mental health promotion types of efforts. I am really eager, as are many, I'm sure, on the call, to hear more about the work that you're doing around the Gatekeeper Plus, and wanted to flag for folks, and Stan, I'd welcome your thoughts on it. I know as a bit of a stopgap, and certainly recognizing that teachers are in a situation where they are on the front lines, and they're often faced with situations and they could use a little support in terms of what to do. The Canadian Psychiatric Research Foundation has a When Things Go Wrong series. We'll make sure to note that in our follow-up communication with you. But it certainly seems to be a it's not a panacea, nothing is, but it's a resource out there that others may not be aware of that might be helpful, and certainly is probably relevant to your Gatekeeper Plus activities. And ditto the systematic review. And on that note, I should let folks know, if you don't already know about a community of practice, this is a very informal network. We connect by phone from across the country. Basically anyone and everyone who works in mental health in schools who cares to be interested in joining us and sharing, learning from each other, what's going on across jurisdictions in Canada, etc. It's a terrific mechanism and is supported by what we call a wiki, an online shared filing cabinet, if you will, that as time goes by and people become a little more wiki-friendly, we hope that people will continue to look at it as a way to contribute and to share the good stuff that is going on out there. Good case in point are some of the items that you mentioned today, Stan. So we do have a mental health community of practice call coming up next week. I'll be sure to share that information with you through Dawn. And then lastly, just want to flag an upcoming National School Health Conference, and as part of that, we will have a day-long symposium related to mental health in schools. That will take place in the Ottawa area at the end of May, and again, watch for Dawn's communication. She'll be sharing it with you. So thanks again, Stan, so much for sharing, and Dawn, for your leadership as always, and to those of you on the call for joining us today.
Yes, I'm just in the middle of a teaching program in Nashville.
Thank you, and I think Stan has finally answered the phone that has been ringing. Thank you, Diane, for that happy face. And I'll just stay on the line if there are any further questions. Stan, thank you. You were able to get your call answered. And thank you, folks that are just writing in your thank yous. And you will receive later the follow-up link to this wiki that you will be able to go on. We'll have some information shared, some of the things that Cindy just mentioned. And so appreciation to you all. Special thanks to Stan. And for those of you that are ready to sign up or sign out, you go up to the top corner to the file and then you exit out. And just before you go, I want to let you know that this time next Tuesday we're having a webinar on troublesome marijuana use. It's called What's with Weed, and it's two presenters, a parent volunteer and an organizer who will be sharing a program that is having good success in Ontario. So that will be coming up next week. So thanks again, and I know some of you are clicking off. I know some of you it's lunchtime, some of you it's mid-afternoon time and school's getting out. So thanks very much, and thank you, Stan, for making it work, and thanks to Tracy. So when you're ready to exit, just go up to the top corner, click on File, and then you'll find the exit there. And Stan, I see there's lots of thank yous coming to you from the folks who've been
thank
listening.
you. I appreciate the chance to meet. I have no idea how to get out of this.
Okay, you Tracy,
how about that?
You go up to the file and then you exit. That'll do it.
Tracy's gone.
Tracy's gone.
I'm helpless. I'm just going to click X, see what happens.
Yeah, that will do it.
What do you think?
Yes, click
All right,
X.
bye.
Bye. Oh,